We are live now, ma'am.
Yes.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 19 of AMOGS Emergency Obstetrics Committee with Erode, Namakkal, Tanjavur, and Tiruvannamalai OBGYN Societies. So it's my privilege to introduce the convener of today's webinar, Dr. Priya Kannappan ma'am. Ma'am is the consultant obstetrician and gynecologist, fertility specialist at Dr. Mehta's Hospital, Chennai, and Garbha Rakshambikai Fertility Center, Chennai, and also executive committee member of Oxy. I welcome you, ma'am, and I hand the session to you.
Thank you. Thank you, Sahiti. So I welcome one and all for this session. So today we have very interesting topics. More to, whatever we are going to deal with every day, day-to-day programs and day-to-day problems we have. So occipito-posterior position, and whenever you leave it to a little more extent, and then we land up with obstructed labor, and then we have our different scenarios and difficulties and emergencies in vaginal deliveries. So today there is a full packed knowledge session is going to be there. So before going on with the session, we will start off with our prayer song.
Kurutvang kalyanam arogyam dhana sampada shubham kurutvang kalyanam arogyam dhana sampada shatru buddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvang kalyanam arogyam dhana sampada shubham kurutvang kalyanam arogyam.
So thank you. So it is my pleasure to invite Dr. Sneha Buhar, Madam. Madam she's also a candidate for the Vice President-elect from the West Zone. Madam is an International MS Signature Award of Phenomenal Leadership in 2020, Asia GCC Award 2021, Dr. Malhotra Individual National Award for Service in the Rural Obstetrics 2008, Durushas Award for National Individual Award 2022, and Individual Award for Championship in Foxy, and a 2 consecutive years for 2020 and 2021, Dira Award 2022, and Anadibai Joshi State Award by the Government of Maharashtra, and almost more than 300 lectures, 10 keynotes, orations, too many articles, and there are loads of committee and loads of chairperson. She has been there, so she's been more popular than that. There is nothing more to introduce. Over to you, madam.
Thank you, my dear. Thank you so much. A very good evening to one and all. My respects and regards to my mentor, Madam Jayam Kannan, and of course, a very good evening to all the respected seniors here. I take this privilege to welcome our chief guest, Madam Gayatri Nirgund, and our guest of honor, Dr. Vijay Prabha. And on behalf of AMOGS, Team AMOGS, the President of AMOGS, Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, the Treasurer Dr. Madhuri Mendare, our immediate past President Dr. Rajendra Singh Pardesi, and our National Coordinator Dr. Parag Biniwale, I welcome all of you. Today we have selected the very important topic, as Dr. Priya has already said, so I'm not going to repeat, but of course, very esteemed speakers with highly decorated CV, and of course, very good orator, both my Madam Jayam Kannan and my dear friend Dr. Charmila. They're going to speak on the said subjects, and of course, I'm going to moderate the panel discussion on labor room emergencies. I thank and also welcome all the president and secretaries of the societies of Erode, Namakkal, and Tanjavur and Tiruvannamalai. I thank especially Madam Chandra Punaswamy, who is my favorite, and of course Dr. Hemlata, Dr. Revati Sadashivan, Dr. Dharani Nalasyam, Dr. Tamil Mani, Dr. Uma Bindra, Dr. Radha Madhavi, and Dr. Alamai, all the president and secretaries of all the 4 societies, and of course the panelists, today's panelists who are very good. It's going to be a very interactive session. I'm sure I've already talked about Dr. Chandra and Dr. Radha Madhavi, Dr. Uma Bindra and Dr. Tarani, Dr. Renju Arun. So all of them, I welcome all of you. Of course, my dear friend, Dr. Priya, who is so hardworking and so sincere in her work, coordinating and cooperating with everybody. So I welcome you, dear Priya and Saiti. I'm also thankful to you for taking up this program so smoothly and seamlessly ahead. So with this, I welcome all of you, and it's my privilege to introduce and invite our president of AMOGS first, just to have a formal welcome from his side, and then I will introduce the chief guest. Over to you, Dr. Kiran, for your precious words.
Thank you, Dr. Sneha. My regards to all the dignitaries who are there, all the chief guests, Dr. Gayatri Madam, Dr. Vijay Prabha Madam, and of course to Dr. Jayam, Charmila, the presidents, Dr. Chandra, Dr. Tamilmani, Dr. Revati, Dr. Radha, and all the entire spectrum of Tamil Nadu OBGY societies. It feels so spiritual that whenever I go attend any webinar of the South, whether it is Kasoga, whether it is Tamil Nadu, or whether it is the Andhra, it is so spiritual. And when I see Jayam Madam, it is really, I mean, she's a teacher hardcore. She's a teacher hardcore, and she covers the entire spectrum. Whether it is, I mean, I was surprised because today she's talking on OPP. Tomorrow she'll be giving some talk on IVF, and I don't know what not information she has in her brain. So just hats off to you, Dr. Jayam, and I hope, wish and pray that in the years to come, someday we will have the opportunity to host your webinar when you will be the president for the National Foxy. So thank you. And Charmila, what I can say about Charmila, I mean, 2 hours back, I was in a webinar with Dr. Chaitanya. Everyone was in so much praise about Dr. Charmila because she's the vice president in charge of the Foxy Endocrinology Committee. And, everyone just adores you. And of course, my friend Parag is there. Parag, of course, in the years to come, 2 years to come, we would request all of you to vote for Parag for the presidential post. Parag is the national coordinator of AMOGS, as well as he's the vice president-elect of Foxy, a close friend of everyone, me, Sneha, and everyone. And Dr. Priya, we are already offering you, Priya Kanappan, we are already offering you honorary membership of AMOGS for for so much work that you are doing in favor of Dr. Sneha. So thank you so much, and my best wishes to the entire program, and my pranam and greetings to Dr. Gayatri and Dr. Vijay Prabha also. So thank you, and let us get on with the program. Thank you so much.
Thank you so much, Kiran, for that warm welcome. And may I have Madam Gayatri Nirgun CB Saiti. So in fact, indeed, it's an honor to me to welcome Madam Gayatri Nirgun, who is the founder secretary of TENI. And of course, she has conducted so many workshops on endogyne surgery, and she started the endoscopy unit in TENI way back 2000. I think lots and lots of achievements and accolades to her credit. So with this brief introduction, may I have Madam Gayatri Nirgun's precious words. So over to you, Madam.
Thank you very much, Madam Sneha. It's a very pleasant evening to be among the esteemed faculty, and I feel really honored and humbled to be in front of you all. I feel that the AMOGS office members, namely Dr. Kiran Kottakoti, Dr. Bipin, Dr. Rajendra Singh Pardeshi, and Dr. Sneha Boyar, you are all not new to the Tamilnadu Societies. You have enlightened us all in so many webinars, and we had been the listeners to your wisdom and to your academic knowledge spreading events in so many places. And I don't have any few words to be present in this esteemed webinar, wherein the emergency obstetrics has been given so much importance, about which we all as private practitioners literally sweat. But we are waiting to listen to the years and years of experience poured into academic feast by none other than Dr. Jayam Kannan, who is a teacher of teacher, as told by Dr. Kiran. but I should add just one sentence to Madam to you. Age is merely a number. There is no way that we all will be able to emulate you in your academic interest, in the cultural events, or in your spiritual wisdom that you would have. You have demonstrated as a person, as a walking encyclopedia, and my humble pranams to you, Madam. And I feel very honored to be the chief guest of this. And she is going to spread her knowledge and wise words about nuances in managing the occiput-posterior position, probably the cesarean sections, how they should be reduced, how the pelvic floor should be toned up by doing some squats or whatever yoga or asanas or exercises. We are waiting to hear and learn from you, Madam. Next is the very important topic by none other than Dr. Chamila, who is our proud, we are very proud that two vice presidents who were extremely academic, extremely well oriented, but well grounded and well reachable and easily approachable persons to the not only to the South Indian and Tamilnadu societies, but to all the members all over the country. And as told by Dr. Chandra, Dr. Charmila, you are looking very charming and evergreen in this gifted sari of yours as well. And we are waiting to listen to you with some beads of sweat is already coming on our face when the topic that has been assigned to you is obstructed labor and probably rupture uterus. But I think with your words, we will feel as though we are in the air-conditioned room. By how to handle that, I'm sure that you would shed that light. Welcome to this, and we are very eager to listen to you, Madam. Next is the session is going to be handled by Dr. Sneha Buyar, and I wish her all the best for the forthcoming Vice President West Zone Foxy election, and we'll be probably listening to you next as a Vice President-elect West Zone, Madam. And her topic is also one of the very, very important labor emergencies. And I also am very glad to be meeting the young Tamilnadu Societies presidents and secretaries. And I welcome the vibrant panelists who are none other than Dr. Radha Madhavi. Everybody knows her vivaciousness. And Dr. Chandra Panuswamy, who is extremely pleasant. Dr. Uma Bindra, Dr. Dharani Priya, and Dr. Renju, both of Joint Secretaries of E-Road. We'll have a feast of the academic session in the evening. And I also am very glad to be a part of this webinar where the guest of honor is Dr. Vijay Prabhacharian. Once again, I all the best for this forthcoming academic feast. And thank you very much for giving me this opportunity to be the chief guest. And I feel very honored and humbled. All the best again.
Thank you so much. Thank you so much, Madam, for your words of wisdom. And with this, we move ahead to welcome Madam Vijay Prabhacharian, who is, of course, a consultant obstetrician gynecologist. And of course, she is from Trichy, so all of us know her very well. And I can proudly say she was an executive member of my committee as breast committee chairperson, and she's the joint secretary of tryouts as well. So we are eager to listen to you, Dr. Vijay Prabha. Over to you for your words. Please
unmute yourself, Prabha. Unmute. Prabha, you have to unmute.
Yeah.
Done.
Thank you so much, Sneha ma'am, for those kind words of introduction. I'm what to say should I, when Priya had called me to be the guest of honor, I was just thinking, frankly, should I be paid to taste nectar? Should I be paid? No. So thank you so much for giving me this opportunity to listen to these stalwarts. I don't think Dr. JM ma'am, Charmila, or Dr. Sneha ma'am, or our panelists are going to leave any stone unturned to tell us what is the latest that's happening in all these fields. So as you're all waiting, I'm also eagerly waiting to let the nectar of knowledge flow. And it's going to be so sweet. And I'm sure after this program, all of us are going to know what the latest has happened in these fields. So as Dr. Gayatri had already talked about our speakers, I would just like to add one sentence. What I would admire with Dr. Jayam and Dr. Charmila and our esteemed panel moderator, Dr. Sneha, would be that, see, there are a lot of talks going on everywhere, there are a lot of webinars going on, and these stalwarts are going to, like give us what is new, what is changed. So we are eagerly waiting to listen to you all. Thank you all so much for giving me this honor. Thank you again.
Thank you so much, Vijay Prabha, for your precious words. And may I invite Dr. Parag Viniwale, who is a very dear friend, the national coordinator of AMOGS, and of course the ICOT chairperson-elect. So all of you know him. I don't think we really need his formal introduction. So over to you, Dr. Parag, for your precious words.
Thank you, Sneha, for those kind words and for the invitation. Good evening. I bring greetings from AMOGS, and it's a pleasure to be sitting next to the President AMOGS as the national coordinator of the state body. Of course, thank you, Dr. Gayatri and Dr. Vijay Prabha, for collaborating with AMOGS. This year, AMOGS has spread its wing to the neighboring states, and there is a good exchange of knowledge which is taking place through various committees, and Sneha's committee is one of the prime committees doing this excellent work. When Sneha told me about this webinar, I had to jump to the opportunity because the two speakers who are going to speak, Dr. Jayam Kannan, who's my most favorite, and of course, very dear friend, Dr. Charmila, are the speakers, and Sneha, who's a friend for last 35 plus years, is going to moderate a panel. So I can't wait to listen to the scientific deliberations. Sneha, thank you very much. Best wishes to your forthcoming election, and my humble appeal to all the friends in Tamil Nadu to bless Sneha with the post that she deserves. Thank you very much.
Thank you so much, Parag, for your precious words. And with this, God's blessings and of course the blessings of the seniors, guests and guests of honor. I would really thank everybody for joining here. And of course, without much ado, we hand over the forum to Dr. Priya Kanappan to take this ahead for us academic session. So over to you, Dr. Priya. We declare that the program is inaugurated. Thank you so much. Thank you, everyone. Over to you, Dr. Priya.
Thank you, ma'am. Thank you. Thank you. Can we have the CVs, please? So it is my great pleasure to introduce Dr. Jayam Kannan, Madam. So Jayam Kannan, Madam, my mentor, Madam, is a Foxy Adolescent Health Committee Chairperson 2013 to 15, Best Committee Awardee, Emerite Professor, Tamilnadu Medical University, Management Trustee of Garbharakshan Baby Fertility Center and Jayam Hospitals, Vice President Foxy 2018. Madam has been the President for Free Legal and Center for Women Trichy since 1992. And she has been a member of all the society possibly very heard. And Madam has received various medals. She has been a medal holder from the MBBS and MD. She has been awarded the Best Paper Award many times. She has been authored many books, and she has even authored in a local language, Tamil. She has given books for pregnant women. And she's been a Lifetime Achievement Award from IMA, MGR University, Trichy, Tirumallur, and Academy of Clinical Embryologists, and the Best Society President Award 2013 Foxy. So, and also she has been awarded the Honorary RCOG Award for her distinguished service and the first Indian to receive this medal. So over to you, Madam. We are waiting to hear about the new, what is new about the Occipito-posterior positions.
Thank you very much for your wonderful
Yeah, I think,
introduction of mine.
Dr. Priya, may I interrupt you? I think
Yes, ma'am.
we have to invite our chairperson for the first section.
Oh, sorry.
Ma'am, chairperson.
Persons.
No chairpersons, ma'am.
No chairpersons. Madam, we had only our chief guest.
Okay, go ahead. No, go ahead, madam.
Yes,
Over to you.
Thank you. The minute the word occipito-posterior is told, I think our head gets scratched and we start feeling giddy. The minute, if only this baby which is smiling like this is not smiling at us, we would have been very happy. That is, it should have been an occipito-anterior where it is trying to face the mother. Now it is trying to face me and give me problems. Now, not moving. So all of us know what is normal position, what is a mal position. This is not something which I have to tell to these people. Why we are worried whether it is front or back? No, front is always better. When somebody is doing backbiting, it is really bad. The same way when the back is on the back side, the 5-minute ABGAR score is very low. Go for neonatal intensive care. The child always not trying to hug the mother. The mother has to stay in the hospital for a longer time with all her problems of infection, hemorrhage, 3rd and 4th degree, perineal tests, and endometritis and whatnot. That makes her sit there in the hospital waiting for the baby to be hugged by her. Now, taking the incidence of occipito-posterior and says, I am with your posterior side. 20% of the occipito-posterior are diagnosed during labor. 1/3 of the occipito-posterior persist as occipito-posterior. We have 27% spontaneous vaginal deliveries. Nowadays, we have 8 and 5% forceps, nearly 59% cesarean. Earlier, it used to be the reverse. 1% we have a failed vacuum and go in for a forceps delivery. And nearly 8, nowadays even 15%, we have adverse outcomes. The co-founders which are there in any case of occipito-posterior is, we would have been having a previous experience with a epidural or a big episiotomy. She would have had induction of labor or augmentation of labor. She might have even had a previous occipito-posterior with neonatal or stillbirth death with a smaller, large baby. And the presence of hypertension, diabetes is not related to the occipito-posterior, but it is a co-founder. Occipito-posterior always invites pre-labor rupture of membranes. Obesity is also a co-founder for occipito-posterior. Now coming to the diagnosis of occipito-posterior, what you find is the fundal height is normal to the period of amenorrhea. In the fundus, you always free the breech, which is whether the front or back. When we do the first pelvic grip and the second pelvic grip, the head is unengaged. The sinciput, which is normally felt better in an occipito-anterior, is not felt in cases of occipito-posterior. The small sinciput, which we feel sometimes, makes us feel, am I looking at a breech? Have I wrongly diagnosed as a vertex? Sometimes the position also is not diagnosed until there is a prolonged second stage, especially if the patient has come from, has been seen in a primary health center or even in a single doctor unit where the hospital is conducting only 4 or 5 deliveries per month. Vaginal examination, is it that easy to make out the occiput and sinciput, the anterior and posterior fontanelle? It is not so easy if you are the patient has landed it with a little prolonged labor and with a caput. In that case, if we have a caput and we are not able to feel the triple chamber or 4-chamber fontanelle, then we have to put the hand little gently up and try to feel the ear. If you are able to feel the ear, yes, we are there with the occipito-posterior. Now, Kiran Kokodi was saying, Jayam Kannan will always be with the what is present. Even though I do not have the chance to do the sonopartogram and obstetric ultrasound. I think many people in Tamil Nadu are also doing it or not doing it. This is the latest one which has been taken up very good support in labor. That is the obstetric ultrasound, both abdominal and transvaginal. If you are doing it with the transvaginal, you can make out where the quadrangle is there, and you can very clearly make out whether it is occipito-anterior or occipito-posterior, whether it is on the left side or on the right side also. Now, ISWAG has come out with the comparative study last year, just 1 year ago, whether your digital examination per vaginum is comparable to intrapartum sonography as designed by the American journal ISWAG. The digital assessment has got nearly 75% error, which all of us as seniors have to accept. And especially in second stage of labor, it is all the more safe. But ultrasound, whether it is in the first stage of labor, whether it is in the second stage of labor, both labors, it is able to make it out very clearly. And because in the ultrasound, we can make out the caput very clearly. The skin of the baby can also be seen very clearly as it is seen here, the skin and the baby's the same. If you have a caput, this portion will be little higher like this. And we always, please note, that is about 5 centimeter away from the presenting part, the ultrasound, especially when you're doing per vaginum, is done. So this is what has been brought out in these papers. Now, when we take the progress of labor, we always have got all the 3 ways of rotation. The first one is the favorable long rotation, which mostly happens with a good flexion and a good pelvic floor and a good contraction, which is in 90% of the cases. And the occiput rotates 135 degrees, which all of us know well. The minute it touches, the occiput touches the muscles of the pelvic floor. The rest of the mechanism is like occipito-anterior, which is going on. I would like to point out here that Ajit Kurkud from Bombay has brought out a beautiful video on mechanism of labor, which he has presented about 8 years ago. I would like to request all of you to just after our this thing, Sneha Bayar's program is over, switch on this video and look at how the occipito-posterior can get itself managed in all the ways, popular, unpopular, comfortable, and dangerous zones. The unfavorable, these things we always are very much worried. We are not worried about the favorable ones. The unfavorable one leads on to what is called a deep transverse arrest or oblique posterior arrest, or when it goes towards the sacrum, it is called persistent occipito-posterior. Now, it's all right. Let it take 135. So far as the woman has got good muscles and it rotates, why should we worry? Our worry is we have all the partograms which have got so much of labor care guide and other things. First stage of labor, 1 centimeter per hour. Second stage of labor within 30 to 60 minutes. All those things do not apply in occipito-posterior. Both first stage and second stage of labor is prolonged. In the first stage, please note that they say the occiput doesn't touch the pelvic floor so easily and declares itself as an engaged occiput. The deflection is also persistent. The driving force transmitted through the fetal axis is not in alignment with axis of the inlet. As there is a big torsion in the neck, it takes a long time for the first stage of labor. In the first stage of labor, when it takes a longer time, the attention to the fetal position is also to be looked up in the second stage of labor. If it does not alter the management in the first stage, we need to keep in the mind the prolonged first stage, and we have to be little patient in cases of occipito-posterior if we have diagnosed earlier. We also have early rupture of membranes, abnormal uterine contractions, and with a long interval which is going on with the rotation and malrotation, and even with the times of arrest of the head, second stage is always prolonged. With the due consequence of prolonged first stage and second stage, we always have a invited problem in the third stage, which is increase in the incidence of postpartum hemorrhage and anal injuries, whether it is third degree or even sometimes complete perineal tear, fourth degree. What will be the mode of delivery in most of these cases? 90% when they rotate normally and favorably, they go in for spontaneous, or sometimes when the patient gets exhausted, we may support her with assisted vaginal delivery. If there is a short posterior rotation and it goes to the occipito-sacral position, we may be able to deliver her with a assisted vaginal delivery as phase to PPs, depending on the structure of the pelvis, whether it is a platypelloid pelvis, whether it's android pelvis or gynecoid pelvis. All these things apply for your assisted vaginal deliveries, but there is always a big chance of perineal tear when we have a phase to pelvis delivery. Now, in the management, we always have to look at early diagnosis, watchful expectancy, and hoping for the descent and anterior rotation. Judicious timely interference as and when it is needed. If not, always plan for an early cesarean also. In the partogram, we always know about the active stage of labor, the second stage of labor, and the third stage of labor. We know very well with the partogram and labor care guide also. Now, we have the partogram of the occipito-posterior, where the rotation occurs instead of this, which is supposed to be going like this, alert line to action line with a short interval. The action line will be prolonged. Please note, this is the action line of the occipito-posterior, and it gets from 9 centimeters. It takes even about 5 to 7 hours to go in for this rotation. This is a partogram of a occipito-posterior. Now, with the ultrasound ISWAG, which has brought out all the detections of the positions, presentations, and the follow-up of rotation and malrotation, if we keep the same curvilinear probe like this and the genital area, you will be able to see the position of the fontanelle very clearly. You see, this is a symphysis pubis down, the probe is going on, the distance is around 5 centimeters, and the axis which is being run is a 97 degrees angle. If this angle is going up like this, that means it's unfavorable. When the angle is going towards the baby, it is to be favorable. And for this, I request all of you to go through the American Journal of the Obstetrics Gynecology 2023 and put the word sonopartogram. You will get all these pictures. This is a labor care guide along with the indices of the sonopartogram is also given. Whoever has got the patients, whoever has got the need, feel very anxious to know about the sonopartogram, please go through this one and get yourself knowledge better, and you will see all the favorable positions, unfavorable, which has been shown in this sonopartogram very clearly. And in that sonopartogram also, they talk about the internal rotation which has to happen, and they give all the angles, and this has been shown very clearly in that journal. And the journal very clearly talks about the neck, sustainability of the such torsion, and the shoulders do not come to the axis line very clearly, and there is always a lag of 45%, which has been shown very clearly in the sonopartogram. Now, coming to the delivery part of it, the delivery is always by extension. Whereas in occipito anterior, we have always said delivery is by flexion. And in this case, when it takes an opposite direction, we have to wait for not less than 1.5 to 2 hours in primi, at least minimum 1 hour in multi. And if you are experienced, and if it is a multi, probably we can even think of doing a manual rotation of the fetal occiput to an anterior pelvic quadrant. If you ask me, Madam, have you done it? Yes, I have done it. I have even done many cases of manual rotation, and forceps rotation is just a thing which is very close to my heart. In manual rotation, the hand has to move as a spatula. And in these cases, after the rotation, there is a restitution. The restitution is the position where it comes to occipito-anterior. The minute it comes to occipito-anterior position, we have to leave the baby so that the baby is able to turn on its own and come out. This is the way we have to hold the baby. If you are doing a manual rotation, keep your left hand on the baby and rotate. It is not with the right hand, because when the right occiput is right side, right ROP, our left hand has to go with the thumb under the symphysis pupil, and your this thing, the little finger on the posterior side, and you rotate it in such a way the thumb goes down. The delay in these cases, this thing, we have to wait in between labor. We have to relax our hand, and during this contraction only, we have to move our hand. So this is one thing. If we have a simulator, you can practice this procedure in your simulator and get yourself acclimatized to this manual rotation. I hope you can see how the fingers are being changed in the direction, and you can feel that the full hand method always helps also by putting your hand under the baby and try to turn. But to my knowledge, to my practical experience, full hand, I am not able to rotate as easily because my hand gets little painful, whereas I find the finger with the thumb and the little finger method more useful than this one for this. Now, this is all when you have diagnosed and you are managing the patient by your own, right from the onset of labor up to the second stage of labor. Now, we have all referral centers where the patient may come referred from a primary health center by a nurse, or from a hospital where they have junior doctors who are not aware of this occipito-posterior, and they prolonged second stage. The patient will land at your center with you have the obstetric expertise. So at that time, we are looking at the maternal fetal factors only. At that time, we are not going to look at is it occipito-anterior or occipito-posterior. Our quick diagnosis is look at the mother, look at the baby, and how to interfere it. And in those cases, all these manual rotations may not be able to help you, depending on whether you are able to feel the fontanelle, the rotation by forceps, or persistent occipito-posterior. Be prepared to deliver the face to pubis or by vacuum delivery if you are confident. Otherwise, kindly shift the patient to the theater only. Now, coming to the forceps for the occipito-posterior. Textbooks always universally advocate the extraction of the occiput directly posterior without rotation. Whereas when the occiput is still persistent as a this thing occipito-posterior in the same position without rotation, or in the deep transversalis position, the rotation is always allowed. Denon in 1955, see how many years ago, 45 plus 24, 69 years ago, he talked about how to apply a forceps in cases of occipito-posterior position and occipito-anterior position. But this has also been accepted even in 2011. That is, even 55 years ago, the same criteria which have been kept in 1955 continues to be the criteria for applying occiput forceps also. The forceps cannot be the actual outlet forceps or your other forceps. It has to be an axis traction forceps, preferably a Keelan's one. Maybe if you have otherwise a good or an axis traction forceps is required. In all these cases of occipito-posterior, one thing I like to make it very clear, the head will not get displaced anywhere. Secondly, there is no chance of cord prolapse because the pelvis is already tightened with the head itself. The rotation is never possible if the head is not engaged. unless it is below the ischial spines. In any amount of forceps application will not be useful for us. And this is one of the this thing which has been shown in 2021, how to apply a forceps, because I have taken a cut and paste. You can see that it has got all the words here, and your forceps has to be steady, forward pull. There is no downward and forward pull in cases of occipito-posterior position. When you are going to apply the forceps for occipito-posterior position in patients who have come after 3 to 4 hours of labor, you can even also sometimes use Simpson's forceps also, which can accommodate the head moldings appropriately. Good forceps choice is also with both Simpson's and with Callan's forceps. Now, when these forceps are being applied, when you are delivering the child, kindly note somebody has to keep a hand in the abdomen, because I have already said the neck is already in a tortuous position. The axis of baby's head coming is not correlated to the axis of the shoulder. Somebody has to give a push on the shoulder. Just how you avoid shoulder dystocia. And in our shoulder dystocia patient, how you put a hand on the above the pubic symphysis and move the shoulder away from your hand. The shoulder girdle in cases of forceps delivery in occipito-posterior also must be done, so that along with the forceps rotation of the head, the shoulder also gets rotated. All these things, whatever I say theoretically, unless one has been exposed to it and practically have felt it, it is not that easy to understand it. I would request all the juniors, if your senior is applying a forceps, please be there at the abdominal side and try to know how the baby moves, so that you are able to take it better in this case. Otherwise, the slippage of the head and this thing also, cord prolapse also can be there once a head is delivered. Now, I want to apply a vacuum. Yes, you can apply a vacuum. Only thing is, you see how the vacuum is not gripping the head very clearly. Some portion of it is free. So, vacuum slipping is very, very common in cases of occipito-posterior. That is why, unless we are waiting slow and steadily giving the vacuum and take good time to see that vacuum gets applied very clearly, just applying a vacuum, within a minute we are trying to extract, we find it difficult to get it. There will always be too many pop-offs, and if there is a pop-off more than 3 times, either you apply a forceps or go to the theater immediately. The trend of occipito-posterior sections going on to cesarean is increasing day by day, and in 2020 it would have been 60%. I will say in 2024, it is reaching nearly 95%, unless the patient comes on her own and delivers phase 2 PBs. Do we have a need to do craniotomy? In cases of prolonged occipito-posterior, where we find a very bad fetal heart, and manual rotation by forceps and other things are not supported, and we are very clear that by doing a cesarean, we are not going to salvage the baby very clearly, craniotomy is the next option which we have to do. Now, what we have to do in cases of this thing, to optimize our outcomes, we have to make this thing in hospitals where there is duty change of obstetricians, day duty, night duty, or one day one person doing duty today, next person doing duty, next day morning takeover. The oncoming clinician may not have felt the prolonged pressure which the outgoing clinician had, and the second stage which is getting prolonged, since she has not been facing the patient so clearly, she will be finding it difficult to wait for hour after hour, hoping for a spontaneous delivery. In all these cases, ultrasound confirmation may be useful, because whatever ultrasound has shown in the previous duty doctors, they say, can be followed by the incoming doctor, and she can make things better, and she can also support the patient with more vaginal deliveries. And selection of the delivery technique is very, very important for these patients, as is reported by Mededge Obstetric Management 2019 outcome. Occipito-posterior, above the level of ischial spines, I have already said, please go for cesarean. If it is below the spine and you feel you are not feeling the spine, you are only feeling the baby's head, please think of venturing with ventouse or forceps delivery. The data in ROP is very much lacking, but the second stage is always more than 45 minutes or 60 minutes. The cesarean delivery rate is more than 4 to 10 times. Operative delivery rate is also high. Obstetric sphincter anal injuries are also much higher, more than 7 times than these cases. So, as a last word, let me tell you, decision-making process in occipito-posterior delivery, population-based studies are not there. Spontaneous vaginal deliveries have occurred in many cases, and operative vaginal delivery is also possible. But we have to know about the adverse outcomes. Assisted vaginal deliveries can always be taken up in these cases, especially in a multigravida. Experience, expertise, and apt evaluation by a continued single doctor is the one which can score more for vaginal delivery. Thank you very much for your patient here. Dr. Priya?
Ma'am, I'm here, ma'am. So that was very mind-blowing, madam. It was like a constant flow of events, like, we were just being there, and it was like such a widely explained, madam. Dr. Vijay Prabha, madam, can you come and give your expert opinion, madam?
Thank you, Dr. Jain, ma'am, for taking us through this difficult labor process, right from the beginning to the end. And we felt like, like after this, going through this muddle, we'll be hereafter able to get some insights into the safely delivering the baby through this difficult occipito-posterior path. And it was with such clarity, and the last comment I would like to add is clarity. Thy name is Dr. Jain. Thank you so much, madam. It was a wonderful talk. Thank you.
Thank you, madam. Gayatri, madam.
Yeah, by God, even last week I had 2 to 3 patients of occipito-posterior, one on the right ROP, the other was on the LOP. Luckily, I also use labor room sonography.
Sonopatograph.
Yeah, but I'm not very comfortable in using the vaginal part, but I know very well to use the abdominal part. And I don't hesitate to wait for that 90 minutes or 60 minutes. And both the times, it was an assisted vaginal delivery of 3.8 and 3.6 kg to be handed over to the pediatrician, and they did very well. And I'm so happy that the sonopartogram part of it, I will go and read it. It was such an enlightening thing, madam. I think Dr. Gigi is doing a very good work on the sonopartogram part of it. Especially the sonography during labor. I had also heard a lot about that, but this was so enlightening.
I think Umaram in Chennai is doing a work on sonopatograph. I don't know about the other one you may have mentioned. Umaram in one conference has presented a paper. Even in Pondicherry, she presented on. But the thing I asked her personal experience, she made it very clear. I am just going through it. That was about 1 year ago. Probably now she would have had more cases in which she may come up with the sonopartogram in Indian scenario. Because our pelvis is something which is different from the Western pelvis. Ours is so much a gynecoid pelvis. Because they have got a lot of platypeloid pelvis in which sonopartogram and other things is very comfortable and they can do it very clear. In our nice gynecoid pelvis as prescribed with the patient with this thing double bump, she has to give us, Umaram has to give it. From South, I know only Umaram. I don't know about
I mean, Gigi is doing not about sonopartogram, but sonography in labor. That's what she is. I mean, both vaginal as well as abdominal. That's what she presented in Kodaikanal also, madam.
Okay. I have no idea.
Okay. Thank you, madam. It was wonderful.
Raising her hand. So, Priya, if you can ask her whether she has some comments to make, and then we can go.
Dr. Vairamani, madam, you have raised your hand. Madam,
Or is it by mistake?
I think it's by mistake, madam.
Okay, no worries. We can go ahead. So, madam, excellent deliberation as usual, and so much to learn from you, madam. Thank you so much.
Okay. So thank you. So I think everybody must be like, so mesmerized. It is like, such a great, complete, detailed about Occipito-posterior. So the madam told us how to go and like, turn it, how to deliver them, what are all the difficult deliveries. And if you get stuck, if you don't know what to do with that, then now comes the next topic where Dr. Charmila Ayyavu is going to tell you when you get stuck, what you're going to do. Madam, we all know she is a vice president for Oxy South Zone 2024. Madam has been the vice president Trichy OG Society, chairperson Clinical Research Committee for Oxy 2016 to 18, ICOG Governing Council member 21 to 25, national coordinator for UNICEF Oxy, Medha Foxy programs, ISAR Gurukul programs, and she has been the ICOG Journal Club. We know that she's done all the series and she's been the convener. Societies, many societies, she's there. And about that, like in most of the award winning and excellently performing person. And I think nobody will not be knowing her. So we just over to you, madam, for the excellent next presentation.
Thank you so much.
One more word, Chairman. The thing, Priya.
Yes, ma'am.
The next thing is a big event waiting in South Con.
Yes, ma'am. Yes.
She has added a fitness program in which nearly lakh of people are joined in the fitness program.
Yes, madam. We are all doing, madam.
Yeah, look at it.
Even if I cannot walk, even if I cannot go work out, I limp and I finish my 10,000 steps.
Yes. See, 1 lakh people joining a fitness program is there in Charmila's program. That means the conference is going to attract more people in her academic situations also. I want to add this comment because I love the way in which the fitness program is every day going on with so many groups of apps being added to it.
So for people who don't know about the fitness program, I'll just give a gist. It is a 1-month fitness competition between all the states. So it's Tamil Nadu competing with Kerala, Karnataka, Telangana and the North Indian states. So it is like all the Andhra Pradesh and all the states which competing with one another. And it is from June 5th to July 5th. So it's a 1-month program. And like I think there are loads of enthusiastic obstetricians. Every day they shoot their videos doing yogas, dances, Zumbas, anything. Pilates. I am like so shocked. I saw one lady like jumping from top to bottom with a stair of like 5 feet or 3 feet. I was like, oh my God, how do you jump like that? And she was just like that doing. So like so much to learn and so much to know that, our colleagues are doing so much good in fitness. So that was excellent.
Lovely. Within 2 days, 89,000 people joined that fitness program. Aha, that was something great. Nice, Charmila. Keep up your good work.
So and we take this opportunity to welcome everybody for South
Vice President, followed by Charmila. Thank you.
Yes, thank you, madam. Thank you for your blessings.
Thank you. So we will welcome everyone for the SouthCon conference by Charmila, madam. And actually, I will take this opportunity to request everybody to vote for Dr. Sneha, madam, who's we are like looking forward to have madam as our next vice president. Over to you, madam Charmila, madam.
Thank you so much. After that very futuristic talk, I would say by Dev madam, because not everybody can talk with authority on Occipito-posterior with the sonogram. And you add always a flavor to any program, madam. And as Priya said, it was a mesmerizing talk. We will take our eyes off of the screen because every point seemed very relevant. So this topic, which Sneha has given me, is obstructed labor and obstetricians nightmare. We think in modern obstetrics, we do not have obstructed labor, but let me remind you, the craze for vaginal delivery at whatever cost to the mother and baby has landed many obstetricians seeing the modern version of obstructed labor. So it's not gone. It is still there. And we need to know what we can do to prevent that. At the same time, balance it with a regular, as Dr. J.D. Tank always says, you can optimize the cesarean birth, but you can never stop cesarean birth because it's not an abnormal form of delivery. It happens when there's a problem to the mother or the baby. So the story unfolds in 2021, 10 January, 11:20 p.m. A lady called Mrs. L, who lives in rural Tamil Nadu, She was having a term pregnancy and labor pains for almost 28 hours. Her husband and an acupuncture practicing father-in-law, they do not trust modern medicine. They attempt a home birth for Mrs. L and she's brought dead to the local hospital. This is not 100 years back, it's 2021. So according to the WHO, a labor is said to be obstructed when the presenting part of the fetus cannot progress into the birth canal despite there being strong uterine contractions. And the incidence is 5% of live births. And remember, it accounts for almost 8% of the maternal deaths worldwide. Very common in sub-Saharan Africa and still parts of Asia. And in India, it is seen between 0.56 to 1.8%, 89% of all deliveries in referral hospitals of India. And the etiology is common as causes CPD. And in developing countries, the CPD is quite common because it's stunted growth of the maternal pelvic bones because of malnutrition. And when there's an early wedding, like your adolescent girl gets married, when there are underage marriages, early childbearing before the growth of the pelvis is complete is going to cause a CPD. Or there may be abnormalities in the shape of the pelvis due to nutritional rickets or osteomalacia. And the cause in labor is when there's an obstruction to the passage of the fetus, the uterus continues to contract in an attempt to overcome the obstruction. The upper segment fibers become thicker and shorter. The lower segment fibers become longer and thinner. And what we commonly call as a physiological retraction ring forms. And when the obstruction persists, the demarcation becomes more distinct and it climbs higher and higher. And then it becomes a pathological bandage ring. The stretched lower segment is very friable now and it will threaten to rupture. And that fetal head now gets jammed in the pelvis. The bladder is compressed between the pubic bone and the fetal head. It becomes edematous, can undergo pressure necrosis, and can become a fistula soon with the condition persists. And with unrelenting labor points, the baby will become hypoxic and then die. The uterus can rupture. But remember that a primary uterus can develop uterine inertia, but the multigravidae uterus will rupture very, very fast. So how do you diagnose obstructed labor? The typical history of a prolonged labor, you'll be able to have a presumptive diagnosis. An examination will help you. But remember, when you have a referral from a small facility or the patient has attempted a home delivery, please be prepared to see obstructed labor. The clinical features, the mother will have maternal distress when she's going for obstruction. She'll be exhausted, can even have ketoacidosis, will be severely dehydrated, will be tachycardia, have tachycardia more than 100 beats per minute. They may have a higher temperature and she'll be throwing very scanty urine. You examine the mother, you can feel the Bandel's ring. It is felt between the tonically contracted upper segment and the distended tender and stretched lower segment. You will see a distended urinary bladder. The fetal heart sounds may be having a distress pattern or sometimes can even be absent. The general examination will show that the vulva is swollen and edematous. The vagina will be dry and hot to touch, and there will be occasionally offensive and pulmonary discharge. The cervix will be almost inflated or hanging like a curtain. The presenting part is extremely molded and jammed in the pelvis, and it's usually a large capital formation. How will you manage when you see a condition like this? Something called an immediate management of the mother, is a general management and an obstetric management. The immediate management is you will start her on IV fluids. At least 1 liter of crystalloids, which can be Ringerlac or amoxicillin, should be given as quick as possible. The bladder should be drained by a catheter. Blood should be taken for typing and cross-matching. Always start her on broad spectrum antibiotics, and remember to add metronidazole to the antibiotic coverage and get an informed consent for the patient and her attendant. Then there will be a preoperative checklist to verify the management protocol which you are going to follow. The timelines of intervention from decision to arrival should be put in place before she reaches the operating theatre. There should be a specialist to review the condition during the process of labor to delivery, either in person, if not available in home, or during a service ward. And cesarean section, if there's an obstructed labor, should be commenced within 1 hour of the decision to proceed. And it should be like less than half an hour should be taken for taking the decision. The next half an hour, the baby should be delivered. And this is the algorithm for managing when you have a baby in the obstructed labor. Always exclude a uterine rupture by a clinical examination with ultrasound. And suppose there's no uterine rupture, the cervix is fully dilated and the vertex is at or below the skin spines. But if the baby is dead, it's better to go for a craniotomy and a vaginal delivery. If it's still alive for your fetus and the cervix is fully dilated, you can attempt a post delivery. But if there's an impending rupture with an over-distended lower segment, do not wait for a vaginal delivery, go for an emergency cesarean section, irrespective of whether the baby is live or dead. I remember for obstructed labor, obstetricians need to know the destructive vaginal operations because when there's an intrauterine infection, the baby has already died with obstructed labor. Delivering the mother by cesarean section because of lack of skills in the obstetrician is going to cause more of complications to the mother because the risk of sepsis is very, very high when you're going to do a cesarean section for obstructed labor. And the role of destructive operations for obstructed labor cases with dead or moribund fetuses is definitely superior to cesarean sections in many studies. And the precautions during cesarean section should follow. Suppose you want to take up for a cesarean because the problem is very, very high. Remember to always put an incision at a higher level, at the upper part of the uterovesical peritoneum to avoid a bladder damage. And put an incision which is large enough to avoid a lateral extension. Remember to have an expert assistant who will dislodge the head if needed. And always check for malpresentation before surgery with an ultrasound. And remember to always explore the uterus of the delivery for downward or lateral extensions, which can be very, very common because of the thin friable oversight. And the dilemma and diagnosis is the balanced view between an operative delivery and preventing an obstructed labor with attendant complications that should be always made with it should be based on objective measurable parameters. And you have to remember that the risk of labor disorders have evolved over the years. So you have to balance it between allowing a mother to go for an obstructed labor or going for an operative delivery. And when you don't know that balance and you're not properly managing, it can end in a moribund status for the mother and the baby. And there are certain criteria for the diagnosis of obstructed labor. You need to know the risk factors of how a mother can go for an obstructed labor. A primary who is in active labor for almost 8 hours, or a multi who is in 6 hours of active labor with regular good uterine contractions. Remember to be very, very careful in allowing her to go into labor for a longer period of time. As ma'am said, when there's a changeover of labor duty, this can happen quite commonly. Like every obstetrician thinking that the mother is going to deliver before labor seems to be low. There are some minor criteria that you have to remember that can lead to an obstructed labor. Suppose the cervical dilatation is less than 1 hour in a primary and less than 2 hours in a multi. There is a protracted descent of the fetal head at less than 1/5 per hour in primary or less than 2/5 per hour in a multi. There's an arrest of cervical dilatation for more than 3 hours in a primary and more than 2 hours for a multi. And the descent is arrested for almost more than 1 hour in both primary and multi. Or there's a prolongation of second stage of labor for more than 2 hours for a primary and more than 1 hour for a multi. And suppose there's a severe capital and molding. Remember, these are all criteria to tell you that the mother is going for an obstruction labor. The classical pattern in a CPD patient is usually there will be an initial cervical dilatation and then there will be a secondary arrest. And it will be it is quite complex when this proposal is exacerbated with Occipito-posterior patients position which Madam was talking about, or when there's a secondary failure of uterine contractility occurring in prolonged labor. Remember, when these conditions are there, there's a high chance of the mother going for an obstruction. And how will you prevent obstructed labor? You will always be very, very vigilant to recognize it early. Go for an immediate intervention when you feel that there is a condition that is going to cause an obstructed labor later on. Utilize a partogram as ma'am was saying to monitor labor and always have a provision for emergency obstetrical care. And the partogram, they have said in many, the USAID itself has come out with a recommendation that when partograms are routinely used in all labors, obstructed labor can be prevented by resorting to an early operative delivery if you feel that the progress is slow. And there's a labor scale which has come now, it's the modified version of the WHO partogram. Here, the alert and action lines which are there in the original partogram have been taken out. And now there's a scale of cervical dilatation. That is, you don't have that 0.5 centimeters per hour or 1 centimeter per hour. There's something called a scale of cervical dilatation to tell you like how fast she's progressing or how slow she's progressing. This will minimize the diagnosis of labor disclosure without increasing the risk to the mother or the baby. And this is the updated WHO partogram of 2019. The differences from the previous one was the active phase, which was defined as starting from 4 centimeters, is now changed to 5 centimeters of cervical dilatation. The fixed 1 centimeter per hour alert and action lines have been changed to evidence-based time limits at each centimeter of cervical dilatation. There's no second stage section in the earlier partogram. Now there's something called an intensified monitoring in second stage. There were no supportive care interventions earlier, but now you need to record the presence of a companion to the patient, pain relief you're given, the oral fluid intake and the posture she's taking for her labor. I noticed that earlier it was just recording the strength, duration, frequency, but now recording the duration frequency is quite enough. And there was nothing like a requirement to respond to deviations in the earlier partogram other than the cervical dilatation, alert and action lines. But now anything which you think is a deviation has to be highlighted. The corresponding response should be recorded by the provider. Why the changes happened is, suppose there's a patient who's progressed rapidly and then she is arrested. If you wait for this patient to go into continue her labor process, it could take more than 4 hours to reach the action line. So you will miss the boat there somewhere, and that may go for an obstruction. Another change which has caused a problem is, earlier the labor was slow as a result of inadequate uterine cavity and activity and has crossed the action line. But suddenly it may progress fast and then it may go on to deliver correctly, and you may think actually the patient is not progressing properly because the action line just crossed already. So that is why they changed the active phase of labor from 4 centimeters to 6 centimeters by the American College. So the standard obstetric care which has to be standard is, you cannot have questionable decisions. You have to decide very, very clearly why you're going to allow her for a vaginal delivery or you're going for a cesarean. You should not delay your preoperative intervention, whichever is needed. And you should not have a reduction in assisted vaginal delivery. You should be ready to do an assisted vaginal delivery by forceps or vacuum whenever needed, and use partograms adequately. When none of this is used, it will lead to substandard obstetric care, and that can lead on to obstructive labor. The recommended interventions to improve diagnosis of obstructive labor is, please post a list of agreed upon criteria in every labor room and operating theatre area, so that everybody follows the same rule as standard protocol. And the midwife in charge and the specialist on call should periodically remind the doctors to adhere to criteria during grand rounds of routine work. Everybody should not do their own thing. There should be a set protocol which a midwife has to follow, the doctors have to follow, as well as a labor room and operating theatre specialists have to follow. You cannot change the protocol, and confirm the diagnosis in case log notes according to the posted criteria when the patient is sent to or received in the theatre. Promote the utilization and interpretation of partogram by regular training on its use during ward rounds. Encourage doctors at the referral points to use posted criteria to confirm diagnosis before referring patients because of obstetric labor. And you need to know the recent changes, the redefinition of labor disorders which has happened worldwide. The intrapartum ultrasound for diagnosis CPD, which Madam has done so beautifully in the talk on Occipito-posterior labor, and the obstetrical dilemma, which is added on to the picture of obstetric labor. So the change which has happened in the guidelines is, American College says active phase starts only 6 centimeters. Before that, you're not supposed to admit the patient in the labor ward. Royal College is still stuck on the 4 centimeters. The progress initially was 1 centimeter, but now they've reduced to 0.5 centimeters per hour. And you will call it as an arrest of first stage according to the American College. If you're given the patient oxytocin, there are adequate contractions for 4 hours and still she's not progressing, there's no cervical dilatation or descent, she's labeled as an arrested first stage. And suppose she's having inadequate contraction in spite of adequate oxytocin, then also she comes with the criteria of category of arrest. Royal College is stuck on to just no progress after 4 hours of oxytocin with adequate contractions, it's labeled as arrest. Second stage arrest, according to American College, is 3 hours now for a priming, and you will add 1 hour for epidural, 4 hours for a priming, and maybe 3 hours for a multi. But RCOT is quite, I think, more logical because they say 3 hours for a priming and 2 hours for a multi. The WHO recommendation is, they've come out with a guideline development group which agreed not to recommend that 1 centimeter per hour threshold and the alert line to assess labor progress. They've accepted that the threshold of 1 centimeter per hour is suboptimal for identifying women with risk of adverse birth outcome. It can cause a false positive finding, and that may lead to unnecessary labor interventions if you take 1 centimeter per hour as the threshold for cervical dilatation. And that's why they've changed to 0.5 centimeter per hour or just cervical dilatation based on the mother's progress. And intrapartum ultrasound should be used more commonly now because for the diagnosis to be made of slow progress or arrest, because malpositions and cephalic malpresentations are well recognized cause of failure to progress. And traditional obstetrics emphasize the rule of digital examinations. But as Madam said, recent studies demonstrated that this approach is inaccurate, that intrapartum ultrasound is far more precise. So a combination of trans-abdominal and transperineal scans will allow an accurate diagnosis of normal and abnormal position, flexion and syncretism of the fetal head. And intrapartum translabial ultrasound is more accurate and will allow for objective assessment of labor progress. And recent studies have evaluated fetal head engagement based on the following parameters, which Madam also put up as pictures. The angle between the pubic symphysis and the fetal head is very important. The distance between the presenting point and the interspinous line to know whether the head is engaged. And the fetal head direct to birth cannot tell you whether it's malrotated. All that will help you when you're doing an intrapartum ultrasound. The advantages of an ultrasound over vaginal examination is it's more precise about the fetal position and station than in a clinical examination. Women seem to prefer in that study of International Society of Ultrasound, they prefer an ultrasound to digital examination. And trans-abdominal ultrasound will help you to find out the fetal lie and position. And the transperineal ultrasound can help you to find out the fetal station. So this is the ultrasound which will help you to find out if there's an occipito anterior or posterior. Very, very simple to be done with the trans-abdominal probe. Occipito-posterior is also very clearly defined when you do an ultrasound. No need to keep on palpating the head and the fontanelles to find out if there's occipito anterior or posterior. And there's something like an obstacle dilemma which more of us, many of us have got stuck to it. And that is a tight fit between the maternal pelvic dimensions and the neonatal size and delivery. Remember that the mothers are becoming more obese now. So there's a double burden of malnutrition and the global obesity epidemic which has reshaped the obstetrical dilemma. And maternal obesity will increase the risk of a macrosomic offspring. And when the mother is short, and along with it, which is obesity, there will be a higher risk of gestational diabetes. And there's another risk factor for a macrosomic offspring. So this dual burden of malnutrition, the obstetrical dilemma, is expected to increase because the obesity epidemic is emerging faster than stunting is being resolved. The other new epidemic that is causing problems is the social media. And on Thursday, July 26, 2018, another mother, couple allegedly attempted home birth with YouTube videos in Tamilnadu, and she bleeds to death. Miss Kirtika, who lived in Tirupur, died due to excessive bleeding on July 22 after delivering the baby at home. So to prevent the 3 delays to avoid obstructed labor, this WHO also brought forward, there should be no delay in decision making. There should be no delay in the lady accessing care, and there should be no delay in receiving timely appropriate care or treatment. So remember to focus on supply and demand interventions to improve outcomes. And to conclude, incidence of obstructive labor, remember, is an indicator of inadequate and poor quality of obstetric care. You cannot say otherwise. And neglected obstructive labor will result from poverty and the prohibiting high cost of maternal care in hospitals, ignorance of patients, illiteracy, obstructed transportation of the mother, a socio-cultural belief to achieve vaginal delivery at all costs, late reference, and the aversion to cesarean hospital delivery, especially after previous cesarean delivery, is contributing to an increase in obstetric labor again. So the take-home messages is, remember that sepsis, postpartum hemorrhage, ruptured uterus are cause of maternal death in obstetric labor. Promote antenatal care service utilization during pregnancy. Improve the referral system. Have an infrastructure that has the capacity to manage obstetric labor at all times. Use partogram in all your labors. Use intrapartum ultrasound when necessary for a better outcome. Reduce maternal obesity. Thank you so much, Dr. Sneha, for the opportunity. I'd like to wish Sneha, 1 second, I'll just put on the light. The current is gone. I'd like to wish Sneha and wish her the best, and she will be seen as Vice President next year. So eager to see you. Thank you so much.
Thank you, my dear friend. Thank you so much. And the talk was way forward. I would say it is really, as you already said, Madam's talk was futuristic, but even your talk is very, very, thought-provoking and really introspecting yourself. Really, it's a need of the hour that whether you should really compel for the normal, so-called normal vaginal delivery, what actually we are not supposed to call even delivery. We are supposed to call it as birthing process. So I'm sure the delegates have been benefited. It was a message talk, my dear. Thank you.
Thank you. Good evening, Radha ma'am. Thank you.
Thank you, Charmila, for that enlightening talk. Thank you so much. the eye opener was, the comparison of the WHO Partograph 2019 and what is happening now, and the labor guidelines previous, present, and the comparison of the RCOG guidelines, the American College guidelines. It was very nice, very good talk on the whole. You have chiseled yourself into an excellent orator. So no wonder you're a most wanted speaker in the Indian and also in the international arena. All the best for your SouthCon conference, Charmila.
Thank you, Jayprabha.
Thank
It's
you so
all
much.
because of my guru, mentor, when she's given me such a path, I have to follow that. Otherwise, I go.
Yes, definitely. Thank you. Thank you, Jay, ma'am. Thank you, Charmila. Excellent talks, both.
Excellent talks, Dr. Madam Jayam Kannan and Charmila. Then the one question to Dr. Jayam, Madam.
Yes, sir.
Madam, previously these our patients used to whatever we say they agree. Nowadays they are asking, you know everything, whether my daughter will deliver normally or whether she will go into cesarean section. When it is you are doubtful, you can take her up for cesarean. So this is the present scenario. What to do with this type of patients, madam?
We had A.L. Mudaliar textbook of obstetrics. Now we have got the Google obstetrics. This Google obstetrics is available to both the doctors as well as to the patient. Today, I had a patient who at 13 weeks, MT scan, she has been diagnosed circumvallate placenta. I told her, stop looking at Google for circumvallate placenta. I said, all these things will be diagnosed only by 28 weeks. The thing, so again, placenta previa was diagnosed at 14 weeks. Now, at 34 weeks, the same doctor gives type 3 placenta previa posterior. If I had told her at that time, stop all of your activities, she would have been really bad. Now, we are also adding problems mainly because we try to be more ethically safe, legally safe. With the result, we are also trying to threaten the patients a little more. With the result, their mind, freedom of mind to think about vaginal birth is already taken away from them.
Yes, madam.
Yes.
We are all doing defensive practice, madam.
Yes, yes, that is what is happening. Today, when 13 weeks, circumvallate placenta being diagnosed. What to say? I told my daughter Priya, please don't send to this, because nowadays the government of India is insisting on fetal expert to do NT scan and target scan.
Yes.
I said, please change this fetal medicine expert who is giving circumvallate placenta at 13 weeks.
Madam, I had put a sentence in my room. Do not confuse your Google knowledge with the experience of the doctor. But feel free to consult any number of
and don't
persons.
question me from Google. Because of my seniority, I can point blank put it on them. Priya Kandapan knows very well how we did a pelvic by a prolapse uterus, transuterine removal of the descended uterus last week. Am I right, Priya?
Yes, ma'am.
We did not do a lateral cutting and went. We went in the middle of the uterus, bisected and took it out. We will be presenting in some conference. Priya Kandapan will be presenting.
Super, madam. Super.
Yes, the uterus was 12 centimeters.
The bowel loops were adhering to the fundus of the uterus. And luckily, we did not open the bowel loop. Actually, there was no other adhesions in the thing, but the bowel loop were adherent to the fundus of the uterus.
She was going on saying, madam, release the adhesion, release the adhesion. I said, unless I know which part of the bowel is there adherent to it, I will not release it just like that. I said, I'll go transuterine and clamp the ligaments from the nearer to the as far away from the midline of the uterus. Anybody would have heard about transuterine prolapse hysterectomy?
No, madam.
No, definitely.
This comes from your experience, madam.
Yes, yes. Priya, my daughter Priya always says, Amma, apply the forces. I want to see the rotation. because it comes like a dance. So nice. So all these things we have to experience it to do it. This
Correct,
Google obstetrics is making us feel very bad. And also this referral, which is a must to these ultrasonographers, is the one which is making things all the more bad. I will frankly put it again. And the patients sometimes, as Charmila has given, their strong will to have vaginal delivery at any cost. The husband standing by with a Google and saying, push like this, push like that. And she gets pushed up.
Most of the complications we land up only by giving this heroism of normal deliveries, madam.
Yes.
Once we had the patient, we were like, literally wanted to counsel. Then the husband told her, you have suffered so long. Don't agree for cesarean. Kindly stick on to this. Normal only, normal only. So even if it is obstructed labor, we hand up with patients who come in the last minute and say, no, we'll try for 2 hours. You wait, we will have it. So nowadays the practice is very difficult, madam.
As Chamla has put, it's a social one, especially Google obstetrics.
What we
Madam, the minute you ask them to give their consent that anything might happen because of the prolongation, and we see the CTG also for the bradycardia or for the variable decelerations, if they still insist on vaginal delivery, I immediately say, whatever, let's not talk. What you want to tell, you please put it in writing and we'll take a consent. I am not responsible for the fetal outcome. I am willing to stay here overnight to give a vaginal delivery, but please do not insist on the outcome. If you want a safe delivery, take the picture of this and you can consult anybody.
Yes, that's true.
I have one
I go
question.
with that guy too.
I have one question. After the perineal tear, after a perineal tear, we repair the tear, suture it. And is colostomy always a must? And nowadays, the gastrosurgeon says you have to put a colostomy. So there is a lot of confusion, speculation over that.
Yeah, things are changing, Vijay Prabha. I have done so many complete perineal tear repairs because the perineal tear repairs are all infra this ischial. The perineal tear repair which you produce by your forceps delivery or by your vacuum or by spontaneous will not be more than 2.5 to 3 inches in the rectum. You don't go beyond the lower rectum. So there is no need for colostomy. It's like this thing, pelvic floor is procedentia. Now they are asking you a sacrocolpus suspension, So you do sacrocolpus suspension from abdominal side and then do the pelvic floor repair. These are the guidelines which have come. This is because of inexperienced people who want to play double safe. That is the risk. If you know well that you touch the apex of the rectum and suture the pararectal tissues, do not take the mucosa, you are very, very safe in obstetric sphincter anal injuries. Once you do the pararectal clearly, it is extremely good. But these people of late, they have framed unnecessary guidelines mainly because their obstetric experience is much less compared to what that is the reason.
So there's no guidelines.
Which one?
There's no guideline.
No, guideline has not yet come because RCOG has not accepted that, So it has not come in a guideline. And still, until RCOG accepts or ASRM accepts, it will not come in a guideline. Only these people, surgeons who are now being called to repair obstetric anal injuries, they because they are used to only colostomy and do anything from below. If they do anything from below, they have to go up and do it for their safety. That is why they are doing. So far, we have to know well how to suture the pararectal tissues appropriately from the apex down. We will be able to do it nicely. Because we have handed over our this thing to urologist and this gastroenterologist. That is the difficulty.
Okay, ma'am.
Can we go to the session 2, ma'am?
Yes. Thank you. Thank you for your listening.
Thank you. Thank you, Dr. Jayam Kannan, madam. Thank you, Dr. Charmila, madam. That was lovely insight from both of you. So we will go to our next session, which will be the panel discussion on labor emergencies. So Dr. Sneha Buhar, madam, she will be the moderator for the session. So as we have introduced, we'll go to our panelists. Dr. Chandra Ponusami, madam. Madam is a president of Namakkal Obs and Gyne Society. Madam has received the Dronacharya Award 2024 from TAPISA and a distinguished Stanleyan Achiever Award 2024. Madam has started the first gynec laparoscopic unit and the IVF center in Namakkal, delivered the first IVF and ICSI baby of Namakkal, FOXY member since 1982 and founder president of Namakkal's Women Doctor Association. She's been the EC member of TNFOG and received the NEMA Best Doctor Award, the Women Achiever Award, and the Best Fertility Consultant Award. Welcome to you, madam.
Thank you, Dr. Priya, for your kind words.
Thank you, ma'am. Dr. Radha Madhavi, madam. Madam is the founder, president, Tiruvannamalai Obs and Gyne Society. Madam is the director of Rajam Multispeciality Hospital and the Institute of Paramedical Sciences. She's a joint secretary and EC member of TNFOG, member of the FOXY, ISAR and the IMS. Madam has done her MBBS from Bangalore and MD from Air Force. Wow, madam, we didn't know that. So, and she's been, like a DNB person as well. And madam has presented many papers in ACOG, practicing gynecology since 1994 till date, conducted 3 annual conferences, JustCon 2017, 18 and 2022 at Tiruvannamalai Medical College. In the field of interest is obstetrics and rural area. So anytime you ask Radha Madhavi, madam, can you come for a webinar? She'll say, no, I would like to make it hybrid so that my people will come in person only. So she's the only person who is having so much confidence. She says that, no, I will bring my people to sit there and listen to me. So welcome to you, madam, and welcome to all the Tiruvannamalai people.
Thank you.
So Dr. Uma Brinda, madam is an MSDNB. She's an assistant professor of OG department in Tanjavur Medical College. She's the present secretary Tanjavur Obs and Gyne Society with the field of interest in higher risk obstetrics and infertility. She has an emergency, so now she's not there. I think hopefully she'll join us soon. So next we'll invite Dr. Tarani Priya, madam. Madam is a consultant at Tarani Hospital, Chennimalai, joint secretary of the E-Road Obs and Gyne Society, MBBS from Annamalai Medical University, DGO from PSG, and she's a former senior resident of the E-Road Government Medical College, Perundurai, organizing committee member of the E-Road OCON 2023, faculty of the South Zone UFOXY 2023, TNFOG 2024 with the field of interest in high risk obstetrics. Welcome to you, madam. So Dr. Renju, madam is a very close friend of mine. She's an assistant professor, E-Road Medical College, UG in Trichy and PG in Thrissur. She's been the faculty in national and state conferences, including the UFOXY, TNFOG, Justosis, Eurocon, and she's a joint secretary of the E-Road Obs and Gyne Society, former IMA treasurer, Darapuram, organizing member of the E-Road conferences. She has the Best CMOG Doctor Award in 2018, Best Sterilization Services Award in 2018, 19, and 2023. So welcome to you, madam. So we'll be having all our panelists. Only one madam, Tanjavur madam is like on the emergencies. So I hope she'll come and join us, ma'am.
Okay, so very good evening to all of you. Once again, I welcome all my dear panelists who are lovely friends. And yes, I have met majority of you. I have met you personally. So very happy to have you as panelists. And may I just take this privilege to welcome all of you. And I hope you can see my screen and it is full screen.
Yes, ma'am.
Yes.
I can see
Yes,
your
ma'am.
screen.
So
Dr.
thank you
Tarani
so
Priya,
much.
madam, can you switch on your video, madam, if that's okay with you?
Yes, ma'am.
Thank you, kindly.
Yeah. So, friends, I'm sure you have listened to the difficulties in labor. You have listened to the various difficulties because of the malpositions. And of course, madam has already talked to you about the occipito-posterior positions. Dr. Charmila has talked to you about the obstructed labor and the reasons behind that. I'm sure all of you will agree to me that labor and delivery, even the textbook says that it is a retrospective diagnosis, that it was a normal labor or it is a normal delivery. It is not that simple that 1, 2, 3 pushes and the baby is out and everything is happy. Childbirth is a sentinel event in the life of a woman and her family as well. Birthing is intensely emotional and physical as well. I'm sure all of you are very happy that this lady will deliver vaginally normally, and within no matter of time, you find that she's in ICU or STU. So, friends, dilemma always exists, whether it is during your training period or even when you are so senior in the field of obstetrics and gynecology. Action is taken, your way of decision and, of course, action, that will depend on whether you are being influenced by the protagonist of timely and appropriate intervention, or it is the masterly inactivity and watchful expectancy. I'm sure all of you will agree to me that we aim at a healthy baby from a healthy mother, and it should be an emotionally fulfilling experience for the mother. So, friends, welcome all of you, and let us all discuss together that how we can do best for all our patients. This first case, I would ask you to take up. This is a 35-year-old multigravida who is delivered at home by Thai. Placenta is also removed, and of course, she is brought to your labor room with profuse bleeding. When you examine, you find that the pulse rate is 120, BP is 90 by 50. So what is your provisional diagnosis? Can we have the first panelist, please? Madam Chandra?
Yes. Good evening, Dr. Sneha.
Good
Thank you
evening,
for this opportunity. Yes. To this patient, she is a grand multi delivered by Thai at home delivery, placenta removed at home.
Yes.
So she has come with bleeding. So we first, we might think that maybe bits of placenta PPH, quite possibly
So
due
it is postpartum hemorrhage, clinical. Yes.
clinical. Yes.
Yeah. Now, when you examined her further, you find that you don't find the uterus palpable per-abdominally. Locally, she's got profuse bleeding, and you find some fleshy mass there out at the vagina. When you do her per-vaginal examination, you don't find the cervical rim. Okay, just a huge mass which is lying there. So, what is your diagnosis now, madam, and how do you go ahead with the management?
Yeah, this is a plain case of acute inversion of the uterus. Since
Correct.
Uterus fundus is not, yes.
Yeah.
Yeah, you are able to see the placental surface of the uterus.
Yes. So, madam, how did you manage this? Now, whether the degree of descent or degree of inversion matters your management, and what are the causes, if at all, we can talk about it?
Yes, that is either it could be incomplete, complete, or we put it as first degree, second degree, third degree. In first degree, only dimpling of the fundus happens. Second degree, it comes up to the cervical. Here it is complete, and it is the entire uterus has come out. So it's a clean case of inversion, complete inversion. So the first thing what we do, our hands will be waiting to push the uterus inside. But by that, before that, we should make that comfortable with IV fluids and her vital signs. Everything is well managed. Then with that, the principle is which one comes out first should go last. So fundus should go the last. So by having in my lab room, if such case is there, then immediately I start put her on IV fluids, vital signs, everything is matched, and there is no bleeding. I will do with anesthetist with my nearby. I will push the uterus inside, having my left hand in the abdomen and slowly pushing it down. Then once it goes inside, I massage it. Then I give the oxytocin between the drip only, and I'll add up some oxytocin. This will be because this for this could be because it's there removed by placenta is removed by dye. So she should have done the traction of the placenta even before that. So that which should have been avoided. Then I replace the uterus if it is a simple case. If it is not happening, then only yes.
Whether you keep your hand inside for some time and for how long?
Yes, yeah. Because usually this uterus will be atonic. Once you remove it, again there is chance of coming fundus coming outside. So
Right.
I will keep it, and my other hand will hold the uterus up in the abdomen side. Then oxytocin will flow. I mean, it takes time. So I give some time for the oxytocin and wait for the contraction, and then slowly I withdraw my hand, and vitals, everything I will look into. This is a simple. If it is simply go inside.
Right. So, madam, if suppose this is not happening, that the correction is reposition is not possible, then what are the other means? How do you go ahead? Suppose
when this doesn't happen means, then what I will do? No,
because she has delivered at home and she's brought to your labor room now. So sometime maybe few hours has lapsed in between. So it may not be possible. It may be difficult because the ring has constricted. Anything else you can try?
Yes. What in our OP, before shifting to any, I flew it inside the thing. I used hydrostatic correction of the inverted uterus will do. I'll introduce, yes, in that I put her in the Trendelenburg position, and then because she has delivered at home, so I expect some infection could be there. So I do some douching, and I usually have this douching tube in our labor room. That with that we push it, the fluid inside, hydrostatic pressure, it might go inside. Then we find out the posterior fornix.
Right.
Then, yeah. Then the posterior, we feel the posterior fornix and place the nozzle in the posterior, nozzle of the douche in the posterior. Then you introduce the fluid inside. So that the hydrostatic pressure, it goes inside.
Right.
This is the next step.
Yeah. And we have to seal the labia minora so that you have to close it. Yes. Okay. Suppose it is also
with the other hand.
Yes, with the other hand, and you ask your assistant to push the fluid under pressure. So, Dr. Radha, when we have seen that either manual reduction or reposition or hydrostatic approach, if this fails, then what will you do? What do you do, rather?
Thank you for this opportunity, madam, and all the best to you. And this would have happened mostly in this case. I don't think we could have been able to do it manually because from coming all the way from home, I think immediately we have to go in for the surgical replacement and not waste our time. Because she's already in shock and bleeding, she should not become more morbid. Right. So we will go in for surgical replacement. Surgical replacement, the patient is draped, put into Trendelenburg, catheterized, midline laparotomy is done, bowels are packed as it is Trendelenburg, and bowels are well packed away, keeping all the resuscitative measures in place. We should place the hands in front and back of the lower segment and below the inverted fundus, and like how we are going to reverse the socks. We just reverse the sock. You do the reverse the socks.
You do the flipping movements from anterior and posterior. Yeah.
Yes. And identifying this exact place is very important. We should be on the front and the back, not on the sides. That is ideally, and use all your front fingers and back fingers to just try to gently push. Be very careful because it's very easy to perforate this uterus.
Right.
And more damage will be done.
Right.
And once you are able to do it like this, it is well and good. If not, we will dilate the constricting cervical ring digitally, and stepwise traction on the funnel of the inverted uterus or the round ligaments. I don't prefer to use Aliza. In fact, I have put green armitage and held the round ligaments. We reply and bring it up. We try to bring it up.
Yeah.
And then next, if this has failed, madam, next step I will go and do is with that kiwi cup. I have a kiwi cup.
Yeah.
I just put it onto the deep inside the fundus and use the kiwi cup. This in my whole life I have seen only 3 inversion uterus, madam, frankly.
Okay.
And this case, kiwi cup would have mostly it will bring it out.
Right.
PV cup has failed, then constriction ring can be cut and then slowly put it inside, put into the uterine cavity and manually push it up, suture it. In fact, even after doing all this, I prefer to give carbitocin. Carbitocin is a life-saving drug. It just makes the uterus to contract very well, madam.
Right.
And,
but carbitocin is to be given prophylactically at the earliest. If at all it is too late, after the oxytocin, it doesn't work.
Yes.
Because the oxytocin receptors usually get, they get blocked or they get exhausted. Okay. So
exactly. Even now, if people are using methazine, even that is a good drug.
Yes.
And then there are other two methods like anterior colpotomy, posterior colpotomy methods.
Yeah.
And earlier decision to do an hysterectomy is not a bad decision, because once the patient is becoming more sick, doing it is not going to help us much.
Right.
We should rapidly go into this condition. Most important, I'll call my friends over to help me, because it's not only moral support. To talk to patients, you need some proper people who talk to patients. The anesthetists, friends, everybody, we need to have good friends.
Yes.
And
so Dr. Radha, after you whatever methods, maybe if nothing has helped and you have to resort to the operative procedure, maybe you have to cut the cervical rim and repose and suture it. Okay, now that you have completed, what post-operative care you want to give this to this patient, because the tone is yet not achieved. So
exactly. We will keep her on oxytocin for 12 hours, continuous bladder drainage 24 hours, send a CPC electrolytes, give her prostadine.
Yeah.
And prostadine is very useful.
Yes.
And
broad spectrum antibiotics, because so much
antibiotics, exactly. And because she's come all the way from home, I prefer to use, in addition to only Zostem, I will prefer to use even Flagyl and also metronidazole.
Flagyl, Metrogyl, and of course sometimes you may even have to add
amikacin.
Yes. So that is the best choice of antibiotics.
Yes. Shall I add something?
Yes, yes.
Yeah, because I have done vaginally, I've maybe few cases I've done only one surgical, because I asked my assistant to put the hand inside and open the laparotomy. I put instead of Alice, I put Babcock's. That is less injurious.
That is what I said. It should be a non-traumatic instrument.
Yes. Slowly pull it out, so that from down they will be pushing the uterus. So it was easier for replacing it. Yes.
Yeah. So
kiwi cup is very useful, madam. I think all of us should try kiwi cup also.
Yes, because as it is, you are trying vaginally, it is not going, but when you are opening it from above and you are giving a vacuum, then that will be easier, because you could not replace it vaginally, you have to resort to the operative procedure, right? So that is the very reason. I think with the kiwi cup or whatever suction, or maybe the step-by-step follow-up with the non-traumatic instrument should help. So I think that is all for uterine inversion, though quite uncommon. I wouldn't say rare, though quite common. I'm sure you must have faced this not only for vaginal deliveries, but also at Caesar, because nowadays Caesarean section is more common. I'm sure when you try to remove the placenta, sometimes, the
adherent placenta.
Yes. May not be adherent, Dr. Radha. Sometimes, just little incompletely separated placenta will come along with, but you can make out that the fundus is coming and you just try to repose then and then only. So it doesn't make any much harm to the patient. But otherwise, I'm sure the vaginal inversion has become quite uncommon, because all of you know that it is because of uterine atony, or maybe because the intra-abdominal pressure is very high, or maybe the placenta is adherent. Best thing is to avoid the mismanagement of third stage of labor. So unnecessary traction without separation or before separation of the placenta, these are the common causes. So wait for the spontaneous separation of the placenta, and of course go for the Brand Andrews technique for placental separation. So that is what is the message for this patient. But if it happens then and then only you can repose so that the patient doesn't
Exactly.
go into shock. Okay.
Exactly.
The vasovagal, it's more than a blood loss. It is the vasovagal or the neurotransmitter.
Shock.
Right. Right. So, thank you, Dr. Radha and Dr. Chandra Madam, for your excellent discussion. Now we go to the second case, Dr. Uma Bindra. I hope Dr. Uma is here. Do we have Dr. Uma Bindra? I think we read the message from her side that she's busy in some emergency, but I think Dr. Tharani can take up this
Yes,
case.
ma'am.
Yeah, so we have this primary gravida, 37 weeks. She comes in early labor. Her vitals, normal contraction. She has 25 seconds every 4 minutes, mild to moderate contractions. Fetal head is floating. Fetal heart is good, normal, 140 per minute. You find that after some time, there's a sudden drop in fetal heart rate, right? Everything is normal and she's just in early labor, but you find that there is a sudden drop in fetal heart rate. What is your diagnosis, doctor, and how will you manage?
Thank you, Sneha ma'am, for your for this opportunity. Actually, it was a little bit scary for me to handle all the stalwarts being in the OG department. And please don't mistake me if I do any mistake.
Yeah.
And ma'am, actually, I'll confirm the vitals because I should recheck the BP, whether it could be any abruption, and will also proceed with
yes,
the
I provide the
diagnosis.
information that it is vitals are perfectly normal. Vitals are
And
perfectly normal.
I'll do a per-vaginal examination, ma'am,
Yes.
to check for the dilatation and whether is there any cord prolapse.
Yeah. So what
And,
are you suspecting here? Basically,
cord prolapse.
A cord prolapse. Perfect. Abruptio placentae and cord prolapse, these are the two differential, you are right. But the high blood pressure and the uterine tonus,
Yes,
the persistently contracted uterus, when it is tense, tender uterus, fetal parts are not well palpable, that will give you a suspicion of abruptio placentae. Correct. So when you do, before going for a vaginal examination, you will go for a per-speculum examination to see whether, to see whether there is a spontaneous rupture of membranes, right?
Okay.
Correct. Why the cord prolapse has happened here?
Ma'am, either because of polyhydramnios.
No, because the head is floating and she's
the head is floating.
Yeah, the head is floating. That is what gives you a suspicion. Okay.
Yes, ma'am.
Once she ruptures the membrane spontaneously, the cord just escapes, and that is why this can be a case of cord prolapse. How do you manage this labor? Dr. Renju, you can take up this. Dr. Renju?
Ma'am, good evening, ma'am. Happy to be part of the panel.
Yeah,
the first and the foremost thing, once I confirm is the cord prolapses, I would immediately call for help.
Right.
My cord prolapse, my diagnosis is based on vaginal examination, so I'll not take my hands out of the vagina. I'll keep it inside and try to push the pressing part inside, ma'am.
Correct.
And the cord, I'll not try to manipulate, because if I try to manipulate the cord, I know that there'll be some spasm of the vasospasm, so this will cause birth asphyxia, so I'm not going to touch that either. I'll try to keep the presenting part up, so head down position if possible, or if I'm not able to do that, I'll put at least 2 pillows below. And another thing I'll do is I'll try to fill up the bladder to avoid pushing and to slow down the contraction a bit. The most important thing that I'd like to do is I'll check the fetal heart rate. If the baby is dead, I'll allow it for a natural vaginal delivery. I'll try to, and if the delivery is imminent, like full centimeter, full dilatation, the head is low, I do some instrumental delivery. It can either be a forceps or a vacuum delivery. If I think that it takes some time for me to deliver by section, I'll immediately rush it to the theater and do a section, ma'am.
Yes. So I think you have said it all. Only one thing I would say, the moment you suspect or you feel that it's a cord prolapse, you will shout for help. Okay. Not only your staff, your assistant doctors, but also you ask somebody to call the anesthetist, neonatologist, everybody around there. And then, of course, you ask the operation theater people to keep everything ready. And by the time when you are examining, you feel, even if you feel that she may deliver vaginally, you have to keep everything ready for cesarean section. Because if the baby is alive, you have to go for rush cesarean section, correct? So now that we have confirmed that, there is a sudden drop in fetal heart, but that means the fetal heart is present, right? So we have to rush for the cesarean section, if at all, at the earliest. Rather, I would say delivery of the fetus by whatever modality at the earliest, right? So whether the cesarean section is available at the earliest, or maybe you can deliver her by instrumentation. By the time, any comment on the mother's position of what is called as knee chest position? What about the tocolytics and amnio infusion, if at all?
Ma'am, tocolytics, it can be given 0.25 mg of Wobutrin. I have seen it being used only once, so I'm not familiar, ma'am.
Yeah.
Amnio infusion, what they say is, if at all...
I would just ask you a question. When do you feel that tocolytics will help? If at all she has strong contractions.
Yes, ma'am.
Right? And which she is pushing down the presenting part.
She's
So
pushing
if she is not pushing, I don't think we should go for tocolysis. Any comment on amnio infusion?
Ma'am, what I personally think is if they give amnio infusion, it is going to give more space for the cord to prolapse some more. So maybe in oligohydramnios it can be given, but otherwise.
Right. So amnio infusion is for something different, what is called as cord compression because of the severe oligohydramnios, right? Not for the cord prolapse. Okay. So now you tell me, now suppose you feel that, there is sudden fetal sudden drop in the fetal heart rate. You find, you examine her, you see, look for the rupture of membranes, there is no leaking. You do her internal examination. There are no, the membranes are intact, but you can feel some pulsations. That is one condition. What is it called as, and how do you manage that?
Cord presentation, ma'am.
Yes.
You're asking about that?
Yes.
Okay, ma'am. So
membranes are intact, but you can feel the pulsations. So that is cord presentation or Phoenix presentation, that is called as. So how do you manage this patient?
And cord presentation, I'll be very careful when she goes into labor because anytime there is a chance that the cord will go in for compression and there will be a hypoxia, ma'am. Number one. Number two, during delivery, I'll be very careful because there is a chance of cord prolapse. It can be occult or it can...
I would stop you here only. Do you allow this patient to go into labor? The cord presentation?
Cord presentation, ma'am, sometimes...
Once she goes into labor and ruptures, she will land up into cord prolapse because the cord is there only. So for Punic presentation, what RCOG recommends, you identify the patient, diagnose the Punic presentation, and you don't allow her to go for labor. In fact, you go for elective cesarean section. Okay, the moment she goes into labor and either she will have cord compression or if she ruptures her membrane, she will have cord prolapse. Right. So this is one situation where Punic presentation, you have to go for cesarean section as elective procedure. I give you, suppose for the same patient, you feel that you find that there is a fetal distress. You examine her, there is no rupture of membranes. There is no cord pulsations also, but still there is what is called as the fetal distress. So you don't find the cord prolapse there. What is this? It is called as occult cord prolapse. Okay.
Yes, ma'am. That I had experienced once, ma'am.
Yes.
Because the patient had gone into labor and suddenly the baby was dead and a small cord was seen on the side, ma'am. So we had actually missed that and...
Right. So it is called as occult cord prolapse. That means, the cord just descends by the side of the presenting part. It is on the side, not in the internal os. So you don't palpate it, but it is on the side and it is getting compressed between the uterine wall and the presenting part during the contractions, right? So that is what it's all about, the occult cord prolapse. Can we avoid this situation, and what are the predisposing factors? How should you avoid it?
Yes, ma'am. So we commonly expect if there are the premature babies, because the head is very small and there is a chance of the cord slipping through sideways, ma'am, number one. Number two, polyhydramnios when the liquor is more. And number three, when there is some malpresentation or some malposition. Right. And multiparas, especially when the uterine tonicity is not normal as it used to be. And any malposition or malpresentation, ma'am. And if we do artificial rupture of membrane, we are not very careful with it. Sometimes, usually a cord prolapse occurs, ma'am. This is the most common cause, iatrogenic cause, ma'am.
Yes. So, Dr.
And apart
Tharani,
from that,
yeah.
yes,
Tell me, anything else, Dr. Anju?
ma'am, if at all we try some procedures, ECV, IPV, they say, but
Annual rotation of little head, suppose it is slightly high up, you have a little free space, you try to rotate and the cord comes down. Okay, that also can happen. So augmentation of labor, as you know, I told you, augmentation of labor, artificial rupture of membranes and manual rotation of fetal head, all these things should be avoided. So this is just a list theoretical. We will not go into any discussion. Dr. Tharani, can you talk about what are the RCUG Green-Top guidelines to avoid all these problems? How to diagnose, when to identify, and how to go ahead?
Ma'am, we should confirm the dates, ma'am. Whether it is a premature baby. So before we'll do a clinical diagnosis and confirm that the dates are correct for the growth, and we should rule out polyhydramnios, ma'am. So that is also both by clinically and also by ultrasound. We'll confirm the AFA status of the patient.
Okay.
And the multiple gestations where the multiple fetal paths should be will be seen clinically. And we'll also confirm whether the presentation is by transverse lie or a breech presentation. And ARM should be avoided as much as should be done only in the active phase of labor.
When the head is fixed.
Yes, ma'am.
Okay. So if at all you find that, you can see the cord presentation, that also you have to identify. Okay.
Yes, ma'am.
Cord presentation. And for such patients, you don't allow them to go into labor. That is what we talked about. This is a Green-Top guidelines. Okay. This is not just the experience or practical. It is a Green-Top guidelines that, once the cord presentation is diagnosed, ARM should be avoided. Immediate preparation for cesarean section should be started. And rupture of membranes, whether spontaneous or artificial, should be totally avoided, and cord prolapse should be ruled out if at all you find there is a drop in fetal heart, or you have to go for internal examination to rule out all this. Okay. So we go ahead with the...
Can I add something?
Yes, please.
It is more common in flexed breech, not with extended breech. Prolapse can rarely occur.
Yes. That is because, madam.
Yeah, because
it fits in well, like a ball for the head. Also.
Extended breech, it's fixed like our head.
Yes.
And we can anyway
Frank breech, I would say.
Yeah. Then we will be seeing the presentation. No, even the placenta is in the fundus or upper position, chances are less. And we do in shifting the patient to the theater concomitantly, we put her in the head low position and track the thing. When we feel the cord position taking her to the theater, we track vagina, then put it in the head low position, then take her, so that it will not come out. That was our practical thing. And
that is what I think Dr. Tharani and somebody said, that you fill up the bladder, or maybe you make very deep head low position, so that you don't allow the presenting part to compress. Can we stop the noise, please? Okay, so we have this now third case, Dr. Chandra madam, for you only. We have this fourth gravida with previous 3 abortions. Now 39 weeks in labor, she delivers a full-term baby girl. Placenta is not expected for 45 minutes of birth. So what is this case, madam? And how will you manage this?
Yeah, this is what I feel is this is delayed placenta, maybe a trapped placenta.
We will just say anything else. We will just label it as
retained placenta. Not expelled after 15. It could be a trapped placenta or adherent placenta.
Yeah, it's a retained placenta. We would just label this as a retained placenta.
Retained placenta.
Right. So, madam, how would you proceed for the management?
Yeah, then I will do first PV examination and find out where the placenta is, and I feel the fundus also. And anyway, it has taken 45 minutes. So whether I'll be seeing whether any bleeding or shock is there. Depending upon that, I will proceed.
Okay.
And I will try
So
to.
she is not bleeding, madam, at present, and already more than 45 minutes have passed, so whether you will do the PV again or you will go for ultrasound?
Yeah, ultrasound. I'll see. Yeah, whether it is adherent, see the myometrium, whether it is thickening or whether it attached in one place to the myometrium, so that I find it as adherent. If it is only retained placenta trap under anesthesia, I will try manual removal of the placenta. If it is adherent means I prefer surgical thing.
Right. That is what is recommended. If before going for any intervention, once the patient is stable, don't make her unstable. You just see to it that she gets IV fluids and everything is ready for operative interventions. Take her for ultrasound. Rule out the morbidly adherent placenta. If it is any kind of placenta accreta spectrum, you have no role to play for manual removal of placenta, correct? And then, of course, before that, meanwhile, you catheterize the bladder, empty the bladder, and just see whether, maybe if once you are sure that she is not a case of adherent placenta, then you will start the oxytocin, right?
Yes.
And then, of course, you will take her for manual removal under general anesthesia. Now, how do you do that, madam?
Yes, as you said, we empty the bladder. Then, under anesthesia, we put hold the umbilical cord with one hand. Then slowly, I'll like this Brandon Russo technique, cord slowly, controlled cord thing, and it is parallel to the
has not separated, madam. So how will you? Because Brand Andrews, you are just removing the placenta when it is separated. But here it is not separated. So how will you separate it?
Yeah, I put my hand inside because already the cervix is open. Put my thing and go through the placental margin entire thing, and I remove the placenta slowly from the thing, because I have done it like that only. And while removing it, one case I have found one fibroid, submucous fibroid was in the fundus. Along with that, I removed it. So that was long time back when these things were not there. But slowly I put my hand inside, gloved hand inside. Then holding the uterus fundus one hand, slowly I go through the margin of the placenta and slowly I remove it.
Separate it.
Yes.
So here, see, you can see here, your both hands are busy with the cord and placenta. So ask your assistant to stabilize the uterus. You, with the left hand, you hold the cord, trace the cord, go right up to the cord insertion. Then you go laterally to the edge of the placenta, and then you slowly try to, separate the placenta all around. And then once everything is separated, you turn it like as if you are turning the pages of the book. That is how it is described. And practically also, we do the same thing, separate and you turn it and you remove it in the same hand. And then what do you do after removing? Then, of course, what is the next step, madam?
Manual.
Yes, Dr. Radha.
We should,
once you remove the placenta, what is the next step? You give uterine
antibiotics we put and oxytocin.
Yes. The oxytocins are already running because you have already taken her up for removal. So oxytocin drip infusion is there. But once you confirm that placenta is removed, you see what observe the placental and fetal aspects.
For cotyledons and all, whether a bit of cotyledon is left empty.
Right.
You have to see the placental surface.
The maternal as well as fetal. Why? Because there can be a subcensurate lobe also that you can make out even from the fetal surface, and from the maternal surface you can see whether any cotyledon is remaining, right?
And you do the scan also to see.
Yes. So once you're sure that you have removed everything, to avoid further PPH, you have to give methergine. Okay, this is a time where you have to actually give methergine, because here you open the sinuses sometimes and they bleed profusely. right? And then, of course, you give her the Occipito-6 continuously, maybe for 6 to 8 hours, correct?
And
Maintain it for 8 hours.
Yes, actually for 8 hours, and then of course you give her antibiotics as well. If at all your patient's uterus is not very well, uterus is not contracted, you may give her carboprost injection also.
Indwelling catheter, we should not forget.
Yeah.
And one more thing, we have introduced, Occipito-6 low into the umbilical vein, so that it gets separated.
Yes.
We have tried that also.
Yes.
So,
yes.
yeah, manual removal. We have injected Occipito-6 in diluted in a saline, slowly introduced into the umbilical vein so that it gets separated from the fundus.
Correct.
That also we have tried. Yeah.
Okay. So with that, I think that discussion is practical and adequate for retained placenta, I'm sure. Only when you are not able to remove, that is because, I would say when you diagnose it as a morbidly adherent placenta, then of course, it is a strict no for manual removal of placenta or any attempt at removal of placenta. You have to take her up straight away for the operative procedure, where you have to go ahead with obstetric hysterectomy at this point of time, what is according to the recommendations. People are coming up with various, for this was actually a patient where you have no problem in removing the uterus also, but sometimes you may have a primary. This is actually para 1. Okay. So if at all it is adherent, then it is little difficult for decision making because it is para 1 only, the first baby. But in a multi, you can straightway go ahead with the obstetric hysterectomy. If it is primary, then of course you have to really think a lot whether you can go ahead with the uterine conservative surgery. Nowadays, people are talking much about it, where you have, so many modifications of these techniques, where you have AMOGS MG, that is you have the cervico-ischemic occlusion of the vessels, or maybe you have the stepwise devascularization, or you have the triple P procedure. Triple P, one is placental mapping, maybe on MRI preferably, and then secondly stepwise pelvic vascularization, and third is what is called as patchy resection. Whenever you have the patchy adherence, there you can go ahead with the patchy resection of the myometrium, and you can spare that. Yes. Okay. So that is what is the triple P procedure. So this is about the retained placenta management. Now we go ahead with the next case, Dr. Radha. This is for you. We have this second gravida para 1 with 36 weeks pregnancy. She comes to you with previous normal vaginal delivery, and she comes to you with labor pains. Para 1, previous normal vaginal delivery. Her vitals are normal. Fetal heart is very good. Cervix fully dilated, fully effaced. Breech presentation at +1. Pelvis is adequate. How do you manage this patient?
Take her, put her on the labor table first. Start and long bore IV. Then
Madam, we have to explain to the relatives and patient. We don't have to be so enthusiastic because it
fully
is
dilated. She's fully dilated.
Yes, still you have to have your team who will be talking to them. You will tell them that, see, you call them inside if you feel so, because you have to be transparent to the patient and
yes,
right?
Keep one of the important relatives inside, and as she shifted to the labor table, conduct breech delivery, vaginal breech, because station 1.
Yeah, you are saying conduct, but that is not in our hand, no. Because if she should deliver by breech, no. Suppose you are all ready, but then she delivers up to halfway and the head gets strapped. So many.
No. Start start an IV line with good contraction. Assisted breech delivery. We'll go in for assisted breech delivery for her.
Counseling is needed prior to.
First, that is what I'm saying. Yes, madam, you can continue. What counseling you want to do?
Yeah, because she has delivered it first time normal. So this time, since it's a breech, we should explain the complications. It may not come out. It should maybe get arrested. And sometimes we find difficulty in the after coming head.
Yes.
then baby might go in for fetal distress. So this is the present situation. But anyway, I will try for, because everything is favorable for us, I'll try for a normal delivery. So that then maybe if you want, you be there, one of your maybe mother or somebody, like the husband, maybe you are here, and
Yes.
then I'll ask. Then
But then, madam, they will say, doctor, you have to take care of her. Because you are a doctor, we have come to you. So we don't know anything. Then what you do?
I'll try my maximum, 90%. Definitely she'll deliver. No problem will come. Anyway, pediatrician is nearby. I'll hand over the baby to the pediatrician. They will look after that.
But then, yeah. So, I mean, both of you have said it partly, but let me tell you, that's it. Even if it is, first normal vaginal delivery, second breech, full-term breech, 36 weeks, not full-term, near-term, but with average size baby. I would ask you what are the factors which can decide, that it is favorable. But then the moment the patient comes to you as fully dilated, fully effaced, you call them inside, explain that even if she has had one normal vaginal delivery, we cannot assure you that this labor delivery will be uneventful. The baby can land up into problem, and there can be problems with the mother also, considering the tears and the instrumental delivery. Even if you have +1 station, and sometimes the breech will take time. You have to keep everything ready for cesarean section, and even the consent has to be ready for cesarean section, correct? To your surprise, when your team is getting the things done, you may find the baby just coming in your hand. Okay, you may be very lucky, right? But it can happen that she is pushing her breech and the baby is not coming out. Then how do you deliver, Dr. Radha? How do you conduct the assisted breech delivery?
Yes. We have two methods, which all of us have learned in post-graduation and we are doing. But nowadays, breech deliveries is becoming rare because most of the breech, second breech and all, we are, because of the risk to the fetus, we are taking up them off for LSCS usually. In what happens in assisted breech, the baby is allowed to deliver up to the umbilicus. We have two methods. We have Maris's Mellivu method, Burns-Marshall technique, and Maris's Mellivu technique.
Before that, that is for the head. Before that, with the breech is coming, so up to what level you are?
Okay. We deliver if it is a frank breech, it's very easy. Most important point, keep the back anterior. And cover with an OT towel so that the baby doesn't take premature gasping.
Right.
And umbilical cord.
I won't say gasp.
Breathing. Yes.
Then just make the umbilical cord loop loose so that it doesn't get pressured. Don't be in a hurry. Gently make the assistant to keep the head in the flexion. On the suprapubic area, ask them to keep the head in flexion so that it doesn't go into extension. With these precautions, then with good contractions, once the breech is coming down, then we remove the legs and then we go into Burns-Marshall technique.
No, even if you allow the baby to deliver up to
in the groin.
Yes, that is only groin is delivered, and the lower legs are delivered. But then you have the whole body, and then the shoulder and upper arms. Then
shoulder and upper arms. We already know about that thing. Right shoulder. They usually slip actually, but we can always hook the arms down. Make sure that
sometimes
the breech
you have the knuckle arm like this. Then how do you do that?
Hand behind. Then you turn the baby so that the arm falls off. Turn the baby to the opposite side so that Yes. Then once the arms are delivered, once both the arms are delivered, keep traction on the shoulder and holding the ankles, making sure the head is all the time flexed, keeping a stretch on the body, rotate with an arc of the circle and lift and put it onto the mother's abdomen.
Okay.
I prefer Burns-Marshall technique.
Okay.
I prefer to do the other one. because I feel neck can get dislocated if I don't keep enough pressure. So I usually prefer to do the Marisusmelli technique, where I am in charge of the baby's traction and keeping one left hand on the malar elements, index and middle fingers on the malar elements, keeping flexion on the head, right hand, index and ring finger, index finger on the right shoulder of the baby, middle finger on the back of the baby, index finger on the right shoulder of the baby, maintaining a stretch on the baby, and with traction, and flexion of the head, I deliver the baby with this technique.
Yeah,
So,
this is for if the head is not coming.
Yeah.
And everything is done. When the baby is delivered up to the nape of the neck, what I do is just allow them the gravity to act.
Yes, hang by its own weight.
Let
it hang by its own weight.
Yeah. If it is not coming, then you hold it at the nape of the neck and slowly traction. It will come up when the assistant suprapubic pressure. If it's not working, then what Radha told, no, that method and all we can try.
Right. So that is what I said. Wherever you need assistance, no enthusiastic or over enthusiastic assistance.
Exactly.
Yes. So you have to keep patience, no unnecessary traction, and don't allow the back to rotate posteriorly. These are the two,
flexion of the head.
And of course, the flexion has to be maintained by suprapubic pressure. Correct? So you have discussed about the once Marshall, you have talked about the Marisusmelli, where your left arm goes, on the two malar prominences, and the right arm is on both the, these two fingers on the shoulders and the
shoulder. Yes.
Pushes little bit the occiput. That will also help in flexion of the fetal head. Then you deliver like this, right? Suppose
one point, madam. Since she is fully dilated, fully FS, station 1, we are tempted to do this vaginal delivery in present situation where there is lot of litigation practice.
Right.
If she had come earlier and she was going to come
not
with
talk
the family.
We will discuss it later. I'm coming to that. We will first deliver this baby and then we discuss how we could have avoided this. Okay. So tell me now, suppose you have not still delivered. I'm telling you that the head is stuck with all these maneuvers. It has not come out. Then what do you do?
Instrumental. After coming head, forceps for the after coming head.
Yeah. So which forceps, the routine one or anything special? How?
I am not right, madam. I never had this issue.
Yeah. So it is Piper's forceps actually. They are the different types of forceps. It has got a pelvic curve also. It is like almost vertical, and the assistant has to literally sit down in front, kneel down. And then you apply the forceps blades and you deliver it. Okay, the assistant has to hold the baby. Okay, and then you put it the forceps like this, and then you deliver like this. Okay, that is what it is. Now, this what we have talked about the forceps. Now you tell me, can we avoid such situations?
Yes.
And how? What are the factors which decide the favorability of the vaginal delivery? What is that to tell
very big baby, very obese mother, not able to
very
assess.
Small baby also, very small preterm baby also, maybe small gestational age baby.
Hemorrhage also. They are known for intracranial hemorrhages. If you do a breech delivery on them.
Okay.
And footling presentation, hyperextended, all these are all important things which will compromise the condition of the baby.
Okay. Then what do you do? Suppose you diagnose the breech, so you should diagnose it near term, explain them, and then you give them an informed choice. That is what RCOG recommends, that once you diagnose it, that after 36 to 37 weeks, it has not converted into head, it has not turned into head, then you explain them, inform them, give them an informed choice for ECV, external cephalic version. If they don't agree to it, or if you do it and it fails, then you give them a choice about the vaginal elective cesarean section or the emergency cesarean section. Okay.
Yes. And I will always instruct them, if they have any doubt, come very early to the hospital.
Right. And if at all, these are the factors, the parity, and that too, how many previous vaginal deliveries she has had, especially how many breech vaginal deliveries she has had. And then, of course, the gestational age, the estimated fetal weight, previous breech delivery, I have already said, the dilatation and station. These are all the parameters. And if the score is 0 to 4, then it is straightway for cesarean section. Okay. If the score is less, then you have to go take care of her for cesarean section straight away. So this is what the RCOG recommendations also. They say that you identify, give them an informed choice for cesarean or elective cesarean or elective vaginal delivery. That is what it says. Okay. So now we come to the next case, and we don't have Dr. J. Uma Binda. So I think we have who is our other panelist, Dr. Tharani, and who
Yes,
else?
ma'am.
Do we have Renju, Dr. Renju?
She said she has an emergency, madam. Maybe she'll join.
I can see Dr.
She's
Renju.
here. Yes, ma'am.
Ma'am, I'm here, ma'am. I'll be here for another 10 minutes.
Okay. So, Dr. Renju, you will take up this case. We have this 34-year second gravida, gestational diabetes. She comes to you in labor at 37 weeks. You examine her that fetal heart is 3/5 palpable, fetal head is 3/5 palpable, fetal heart is good, 48. Per vaginal examination, she's 2 centimeter fully effaced when you examine initially. The labor progresses well, and after 6 hours, it is fully dilated, fully effaced vertex at perineum. With 20 minutes of full dilatation, the head is delivered, but the shoulders are stuck. What is your diagnosis? How will you manage this?
Shoulder dystocia will be the diagnosis, ma'am.
Yes.
So as soon as I diagnose this, I'll ask her, as usual, I'll shout for help, number 1. Number 2, I'll ask her to stop pushing.
Right.
And I'll ask her to come to the edge of the table, ma'am.
Okay.
And I'll put a McRoberts maneuver, ma'am. I'll ask her to, the legs will be completely flexed on the highly flexed legs
But
over
she
the
will not be
abdomen,
able to do on her own, right? Hyperflexion,
Yes, ma'am.
somebody needs to assist.
Okay. That will be the 4th thing, ma'am. And after that, I'll ask her and another assistant to give a suprapubic pressure. I'll try to deliver the shoulders, ma'am. Anterior shoulder first, followed by the posterior shoulder.
Okay. So suppose she doesn't deliver with this McRoberts maneuver with suprapubic pressure, you said. Usually 80 to 90% of these women, they deliver with this. But if she doesn't deliver, then what will it do?
Then I have read only books, ma'am. I have never even seen it. Something called as the Wood's-Coxtrue maneuver. We try to rotate the posterior shoulder and try to bring it under the pubic symphysis and try to deliver it, ma'am. I have never seen it even.
Okay, okay. So we have actually managed this patient, so we can tell you better that, you can see even the same nursing staff who will help her in hyperflexing her upper and the lower limbs, the thighs, they are hyperflexed on the abdomen, and the knees are also flexed, and she is, pushing or giving the suprapubic pressure at the right means the proper shoulder. So how do you decide that where to give the suprapubic pressure, whether it is on right side, left side, or how do you decide that? And how does this McRoberts maneuver help?
It widens the pelvis, ma'am. The anteroposterior diameter, it widens a bit. And if I push the shoulder diameter, the intertrochanteric diameter is going to reduce a little bit.
Correct. The acromial diameter is reduced. That is correct, because you're pushing it towards the chest. Both the acromion, they're coming together. So and of course you are helping straightening the pelvis. It's not only widening but straightening the passage also. Correct. And then when sorry, I just wanted to tell you that you have to which side the pressure. It is here in this picture. You can see very easily that the side of the occiput.
It's applied to the side of the fetal back, ma'am.
Yeah, fetal back. That is fetal occiput, right?
And it is in the downward direction into the pelvis.
Yeah.
And it will be laterally towards the opposite side in the order to form the adduction of the shoulders, ma'am.
Right. So you have to just give suprapubic pressure. Where do you push the shoulder towards the midline? That is very simple to tell you that. Okay. so that you have this next maneuver, that is the Wood's corkscrew maneuver. Here I have shown you the pictures how it is done. Okay, you can make out here, you know, see how it is, the hand is moving here. There's somebody has to give not fundal pressure but suprapubic pressure. The uterus is just stabilized from below. You're putting your two fingers and you're just trying to rotate the shoulder through 3/4 of the circle, right? The posterior one has already slipped. You can see here the anterior shoulder is struck. Is it correct? Is the concept clear?
Yes, ma'am.
The anterior shoulder is stuck and your posterior is already below the level of the obstruction. So when you rotate it completely through 3/4 of the circle, the anterior one becomes the posterior now, and then it gets delivered. Okay? Do you get it?
Yes, ma'am.
Yeah.
Yes, ma'am.
It's very clear that the posterior is already down. Okay? So it has escaped it is not impacted here. The anterior one is impacted. So when you rotate it, the anterior becomes the posterior. So even the posterior, now the one which has become posterior, that will also escape. So both the shoulders escape. Okay, and the baby is delivered. Not to do here, and what are the precautions? What are the precautions?
It's not pull the head, ma'am. It might result in brachial plexus injury.
Right. Not to give any fundal pressure. Not to give any fundal pressure, because that will worsen the situation. That will impact more. And also not to apply excessive pressure or traction. Okay. Of course, you have to tell her continuously push in a proper direction, and then of course the assistant has to do his job. That is what will solve the problem. Now, should we go ahead with the last case, Dr. Tharani?
Yes, ma'am.
For you. This is the last case now. So we have primary gravida with 39 weeks pregnancy. She comes to you in spontaneous labor at 4 p.m. Vitals are normal, uterine contractions are 20 seconds every 5 minutes. The head is 3/5 palpable. Fetal heart is good, and the cervix is only 2 centimeter, but 75% effaced. How do you monitor I think this we'll skip. This is a partogram. Charmila has already covered this. So this case we will skip. We have one more, this case. So Dr. Tharani, you will take up this case. We have this 37-year-old second gravida, previous cesarean section for fetal distress. And now she comes to you in labor. Contractions, 2 to 3 contractions in 10 minutes. Each contraction lasting for 30 to 40 seconds. That is good contractions. Cervix is 6 centimeters, fully effaced. Vertex is at station 0. And at full dilatation, there is severe bradycardia. Okay. So the vertex is at +1. More than average bleeding is seen. No contractions. When the bladder is catheterized, blood tinged urine. What is your diagnosis?
It might be a scar rupture, ma'am.
How will you manage this?
So I'll take up the patient for C-section.
Correct. But then you have to explain them that it is probably a ruptured uterus, and there's no way then to go for cesarean section, and you have to tell them that it is not only plain cesarean section, but it can be
laparotomy.
Yes, a laparotomy where you may have hematomas or hemorrhages inside the peritoneum, hemoperitoneum, and you may require blood transfusion and may require extensive surgery, including obstetric hysterectomy. That is so these are all the risk factors during pregnancy where you can have this ruptured uterus. So during labor, when you have this, of course, you have the various situations where you actually have this rupture of uterus during labor. Sometimes you may have silent rupture of uterus before the labor also. So this is the list of, where you have the metroplasty or the myomectomy, or maybe previous classical scars, okay, hysterotomy, which used to be like, vertical previously, and placenta accreta spectrum, where you have actually had the scar weakened previously. Okay, so all this. So what is the take-home message here is intelligent anticipation, skilled supervision, prompt detection, and effective institutional therapy can prevent the disastrous consequences. Of course, not to forget the communication and documentation. So with this, I just make an humble appeal to all of you that myself, Dr. Sneha Bhuyar, I have worked as served the FOXI since last 21 years. I've served the FOXI in various capacities as chairperson breast committee, also the ICOG, the academic wing, as governing council member, and I'm still the chairperson for AMOGS Emergency Obstetrics Committee, and I have served also as chairperson Medical Disorders Committee. I'm at present the SAFOC, South Asian Federation of Obstetrics working group of breastfeeding member, and I'm working for all this organization. Just for your information, let me share with you that I'm the first lady IMA president for Yavatmal, my place, and I'm the state chairperson for IMA Maharashtra, that is my state, who is serving as chairperson for Mission Pink Health, and I'm also the convener for PCP entity of the state of Maharashtra. So with this, I appeal all of you and request all of you to support my candidature as FOXI Vice President West Zone, and I request all of you to vote for me. So for West Zone, you have 2 votes. I request you, if you feel I deserve, please make me as your first choice. Thank you so much. Thank you so much, everybody, all the panelists, for being so interactive. You have added value to this discussion, and I can see Madam Gayatri Nirgun still there listening to the discussion. I'm very thankful to you, Madam. And if you have, please do bless us by your comments.
Of course, madam. Last time itself, we voted for you also. I wish you all the best for the forthcoming election for Vice President West Zone FOXI, ma'am. And the panel discussion was extremely enlightening, and especially the inversion uterus. The new techniques was also very, very useful. I mean, previously it used to be only a hydrostatic replacement or manual replacement followed by surgery, but the addition of kiwi and suction thing was very, very useful tip. We hope that we don't get into such
I know.
difficult situation.
I hope nobody lands up into this situation.
Yes.
But we have to be prepared, because being obstetricians, we are not sure where we land up into problems. Obstetrics is a bloody field, but very unpredicted.
Very true. Very
yes.
Not only that,
Ready with the prediction, we have to go ahead for the preventive measures, and we have to be prepared for to face whatever situation comes to us.
Yes, ma'am. That is true. Very nice panel discussion on all the 5 cases, ma'am. Very nice discussion.
Sorry,
All the
in between I
panelists
had to
also.
go. I'm sorry, I had to go in between. I'm so sorry.
No worries.
Excellent webinar, Dr. Sneha. We feel as if I am in the labor room doing PG, sitting on.
All of you are so experienced and knowledgeable. It is just a mutual discussion. I think we just discuss it as if the attendees have to be benefited, because everybody is talking about the art of vaginal delivery is dying, and I'm really sorry to say that. But we obstetricians who are working very hard. I'm a private practitioner fully since last 28 years now, though I was a assistant professor in government medical college for initial 5 years. But I mean, as an obstetrician, I really feel that bad that people are not taking interest. The new generation is not going for obstetrics. So it's really
true.
Yes. So sorry, madam, there is only one question in the question and answer session. I know it's very exhaustive. I'll just want a small answer, and then maybe we'll wind up for the day. If the footling is present in a fully dilated cervix plus 2 station, you see the foot.
No.
Only foot.
No to the vaginal delivery. Even if it is fully dilated, there is no question of vaginal delivery of a single footling. Okay, if it is, maybe you carefully do the internal examination, see that you are feeling, either it is
breech.
2 feet and the buttocks also. If it is a complete breach, yes, go for vaginal delivery. If it is isolated footling presentation, then of course strict no to vaginal delivery and go for emergency cesarean section.
Lovely,
But
madam. Lovely.
maybe
That was
for a
very clear.
34, 35 weeker, ma'am, it might
Yes, it
still
is.
be possible.
Yes,
It
yes.
might,
But madam, we will just take it as blessings, I think, because in this era of,
litigation.
Litigation.
yes, we will not go for any heroic opinion or maybe procedure. If it comes as a blessings, I think that is welcome.
And nowadays, the
But patients
neonatologist
themselves opt for only elective C-section
Yeah.
when they come with the Google research breach, ma'am. So that is an
There
additional.
is one chance when we can do some ultrasound, find out presenting part is nearby.
Right.
Then what we do, like a second of the twin, when it is breach, what we do, we rupture the membranes and take the foot away and do it as a breach, no?
Yeah, that
Maybe
is for
we try. Yeah.
Second features of the twin, definitely yes.
Yes.
For a single isolated first, the only features where you are not sure about the delivery, then definitely no. So I think, we just keep on spreading our knowledge and, keep on sharing our experiences as well, but we have to stick to the recommendations, what are
Guidelines.
the ethics and the evidence. Yes. So we just take care of everything so that we are safe and our patients are also safe. So with this, I thank all of you once again. And I just thank all the
Thank you,
participants.
madam. Thank you. I would like to thank all the
Thank you,
panelists.
madam.
I would
Thank
thank
you.
our
Wonderful.
chief guest to stay till the last.
I
Thank
know.
you, Gayatri, madam. Thank you.
So much.
Thank you very much, Sneha madam. Thank you very much for the wonderful panel.
Thank you.
All the panelists were also excellent. Chandra ma'am, Radha
Thank you,
Madhavi
thank you.
ma'am, Dr. Renju, Dr. Dharani, and
Yeah.
I think we missed Dr. Uma. And
Yeah.
as usual, Jaya ma'am and Charmila ma'am had been extremely, what to say? I mean, their talk was out of the
Yes.
thing. It was
Priya
fantastic.
Kannappan did a wonderful job.
Thank
And
you,
Priya,
madam.
you did
Thank
a very
you.
nice
Thank you.
way of
Yes,
conducting
I
it.
would just make one comment here, as madam has said that last time also, all of you, but I know that very well. The whole India has voted for me, and that's a very reason. Even though 10,657 votes have been, but these are elections, and there are many other factors, and that's a very reason I would urge you all that not only your votes, but all your friends and colleagues, please ask them to vote for me so that, there is no, there is no problem, I would say. So thank you so much.